Good morning, everybody. Welcome to this wonderful beginning. It is very hard to come in the morning and be on time, so thank you so much for being here. This is an important milestone for all of us, and several of you have witnessed this year after year. The first conference in this series was done in 2015, and there was a lapse of 2 years during the COVID time. So now this is the 10th. So we are in a very, very special edition of this program. So welcome all, and without any further delay, we want to start the first session. We have a request to all the faculty members to please manage the time efficiently so that we are always starting the next session at a very right time. So with this, I invite my co-chairs for the first session, Dr. V.K. Mishra and Dr. Georgie Koshi. Please join in on the stage to start the first session. So our first speaker is the stalwart of this conference. He has attended every conference while he was in UAE, and now he is in India for last 4 years. And he's making all the special efforts to come over. So we have this great pride in inviting Dr. P.K. Gupta. He's a professor and head of department in Aurobindo Medical College in Indore. He's ex-consultant from Ministry of Health UAE. So I invite Dr. Gupta. Please give him a big round of applause. He's our very worthy speaker. The topic is expanding the horizon of cardiovascular prevention, inflammation, metabolism, and beyond. Please, Dr. Gupta.
Good morning, ladies and gentlemen. Let me extend a very warm welcome to each and every one of you this Sunday morning. And at the outset, I would like to thank Dr. Brajesh Mittal and his entire team for giving me this opportunity to talk on very important topic, that's expanding the horizon of cardiovascular prevention, inflammation, metabolism, and beyond. We all know that the cardiovascular disease is the leading cause of global mortality, and it is the ischemic heart disease which is leading the pack, and United Arab Emirates is no exception to it. And you can see that the mortality even in the UAE is led by ischemic heart disease. We all treat standard modifiable risk factors by GDMT. In spite of that, the recurrent events keep on happening, and this is happening due to the underlying residual risk. And this residual risk is contributed by residual inflammatory risk, residual thrombotic risk, residual environmental risk, and residual environmental risk. The two important components, one is pollution, in which air, noise, light, heat, and fires and soil. Air pollution plays a very important role, and I have already spoken on this topic 2 years back on the same platform. Coming back to the infections, and especially respiratory COVID and periodontitis, and now vaccinations play a very important key role in cardiovascular prevention. Coming to the residual social risks, all social determinants of health plays a very important role here, especially social and mental health, anxiety, loneliness, depression, and social isolation. I am going to concentrate predominantly on residual inflammatory risk. So this is the opposite-on study just presented 2 months back in ESC heart failure. And in this study, it was found that the patients of atherosclerotic CVD, heart failure, CKD, and atrial fibrillation have got 2 in 5 have got evidence of cardiovascular inflammation. In fact, if you analyze all your standard modifiable risk factors, starting from smoking, bad dyslipidemia, hypertension, periodontitis, diabetes, and infection, They all mediate the maze by pro-inflammatory milieu. And if you implement lifestyle intervention, they all act as anti-inflammatory agents. And cardiac, chronic systemic low-grade inflammation leads to the release of IL-6, leading to the vascular as well as myocardial remodeling, producing atherosclerotic CVD and heart failure. Acting on liver releases HSCRP, which helps in assessing the CV risk assessment. And this is the ACC consensus document released last year on inflammation and cardiovascular disease. And if you can see here, these are the patients who have got the non-obstructive CAD. Only perivascular inflammation detected on CCTA or on PET. These patients are 2.5-fold risk of CV risk if you don't have inflammation. And if you integrate the data of CCTA with the AI algorithm, the results become much more useful and it changes management in 45% patients. So it becomes much more cost-effective CCTA with AI algorithm. So if you just look into this data, there are no standard modifiable risk factors, SMU, ref less population. Just measure the HSCRP. If it is less than 1, your patient is at low CVD risk. If it is more than 3, your patient is at high CVD risk. Then the debate is started. Should we give statins to this population? Answer is certainly yes. And if you see in this population, no standard modifiable risk factors, only HSCRP is raised. And if you give 20% of rosuvastatin, there is 38% reduction in CV events. And very important drugs, GLP-1RA we are all using in day-to-day clinical practice, and they reduce MACE because they are very potent anti-inflammatory agents. They reduce HSCRP up to 48%, IL-6 by 18%, and CD163 by 10%. Not only that, GLP-1RA, they produce immunomodulation by reducing inflammatory markers, by decreasing the granulocyte precursors which are pro-inflammatory, simultaneously increasing the vascular regenerative progenitor cells, leading to the healing and decreasing MACE. What about in secondary prevention in post-MI population? Again, immune cell dynamics driving both plaque modification, that's the vascular remodeling, as well as myocardial remodeling. And that's why the plenty of trials are going on in this population with the anti-inflammatory agents, including colchicine, goflicizumab, anakinra at IL-1R, IL-6R or tocilizumab. And this is a very important compound, and a lot of trials are going on, ziltivekimab at IL-6. And if you look into the different inflammatory pathways and the trials which are going on, at IL-1, we have got canakinumab and anakinra, IL-6 tocilizumab and ziltivekimab. C5 we have got paxilotuzumab, and for systemic inflammation we have got losmapimod, methotrexate, colchicine, cyclosporin, infliximab, and etanercept. If you look into the data of colchicine from 2013 to 25, and the meta-analysis which published in 25, there is significant reduction in CV events. And that's why 2024 European Society of Cardiology guidelines, they gave 2A recommendation for colchicine in secondary prevention. Not only that, just last month, EMA has gave clearance to colchicine for secondary prevention. This is just last month. So what should be our algorithm? When we discharge patients of ACS, especially those who have got the extreme high risk category, that means those who have got recurrent events or the polyvascular disease. As per ESC guidelines, the goals are LDL should be less than 40. As per Lipid Association of India guidelines, the LDL should be less than 30. And once in lifetime, one should measure the LP-little, and if it is more than 50, your patient belongs to the high risk category. We all start with high intensity statins. If your patient is at goal, it's fine, just follow it up. But if your patient is not at goal, then introduce ezetimibe, benzoic acid, and PCSK9 inhibitors, including evolocumab, alirocumab, and inclisiran. Once you have achieved the lipid goal, always look for residual inflammatory risk. Measure hsCRP. If it is less than 2, continue follow-up. If it is more than 2, consider colchicine 0.5 milligram a day. So that's the algorithm which we have to follow. What about the heart failure? And again, the Posidon study, and they have found 40% patients of heart failure have got underlying cardiovascular inflammation. And there are plenty of trials are going on in heart failure patients with anti-inflammatory agents. NRP inflammasome, we have got the cold heart failure and Colca with colchicine, Cantor's heart failure with canakinumab, and DHeart2 and heart with anakinra. With gilteritinib, we have got the Hermes and Anthena. Then etanercept, we have got recover, innocent, and renewal. And for MPO inhibitors, we have got the satellite and endeavor trials. So a lot of trials are going on, and we have to wait for data in this field. So ladies and gentlemen, about the inflammation and cardiovascular disease, one has to remember, in spite of GDMT, there is a significant residual risk contributed by inflammation. And inflammation is not uniform. There are distinct inflammatory endotypes, and they are likely to shape progression and outcome. And that's why one size fits all cytokine blockade doesn't help. You have to individualize as per individual pathway. hsCRP more than 2 is predictor of future cardiovascular events as well as a marker of inflammatory risk. IL-6 assays are still not widely available. So always remember the residual inflammatory risk after taking care of standard modifiable risk factors by GDMT. Coming to the risk contributed by infection, and again, this is the ESC statement, vaccination as a new form of cardiovascular prevention. These are the infections which can induce MACE in healthy population and population at risk. And if you vaccinate them, there's a significant reduction in MACE. And that's why the ESC guidelines recommend the flu shots every year, pneumococcal every 5 to 10 years, and herpes zoster 2 shots. Coming back to the metabolic health, in Asia, cardiometabolic health is a serious problem. And if you really analyze all the components of CKM, cardio-kidney metabolic syndrome, obesity, hypertension, dyslipidemia, diabetes, CKD, they all cause MACE mediated by inflammation, both vascular inflammation leading to atherosclerotic CVD and HFrEF, and myocardial inflammation due to the vascular and myocardial inflammation leading to fibrosis and hypertrophy producing HFpEF. And these are the ACCHA guidelines for CKM just released 3 days back. These stages we are all aware. Just we want to arrest the progression from just collection of the risk factors and the mild disease progressing to the significant CVD. So we have to screen and arrest this progression. And those who have already progressed, we should try to reverse it back. So these are the guidelines, and to have cardio, kidney, renal protection in this CKM population, there are 4 pillars: RAS inhibitors, SGLT2 inhibitors, non-steroidal MRA as finerenone, and of course GLP-1 RA. So there is expanding horizon of cardiovascular prevention in 2026. In spite of treating standard modifiable risk factors by GDMT, we have got the lipid risk, thrombotic risk, inflammatory risk, metabolic risk, infection risk, and psychosocial and environmental risk, and more to be discovered in future. So ladies and gentlemen, I will finish off with these key messages that despite adherence to the modification of standard risk factors by GDMT, patients keep on having recurrent events. And this is due to the underlying residual risk, as I have already explained in the previous slide. So, new therapeutic approaches in the form of low-dose colchicine, pelacarsen, PCSK9 inhibitors, antithrombotic therapies, GLP-1RA, SGLT2 inhibitors, EPA offer new therapeutic avenues for reducing residual risk. In future, artificial intelligence will have a pivotal role in analyzing complex data sets to enable precise stratification of patients to have identify and tailor-made therapeutic optimal management. So I will finish off with a quote of Sir Richard Dole that premature death is inevitable, but premature death is not. So in every patient after GDMT, try to identify residual risk, address it comprehensively to prevent premature death in your patients. Thanks for your kind attention, and thank you.
Thank you, Dr. P. K. Gupta, completing your enormous and detailed talk within the limited time. Thank you very much for we will have questions and discussion after all the three talks. Let me invite our next speaker, Dr. Amer. Dr. Amer is an interventional cardiologist working in Medcare Hospital, Dubai. He is taking the next 15 minutes to a very important talk, which is wearables, technology, telemetries, and in era of artificial intelligence, these wearables has enormous importance. Dr. Amer.
Is the audio okay? Yeah. So the topic today is called Connected Cardiology, and I'm going to be talking about this over the next 15 minutes, primarily focusing on telemedicine, remote monitoring, and wearable devices. So this is the outline of my talk. I'm going to talk about the framework of how we should interpret these emerging technologies, primarily focus on signal capture all the way to accountable care. And really, there are 5 important parts of the framework for any remote monitoring system. The predominant part of my talk will focus on how these systems relate to heart failure, and then I'm going to focus on wearable AF detection, which are the primarily 2 big domains in this field at the moment. So if you look at how this field has evolved, it's now looking like it's not just using devices to detect something. It has to end up into an actionable, meaningful outcome. So this is a nice figure from a review article published in JACC in 2023. And it just kind of shows you how complex or how simple it can be. The remote monitoring system could involve implantable hemodynamic monitors. It could be rhythm device sensors, integrated cell phone apps, wearable sensors. Data's processed, and it could involve a single clinician, could involve an algorithm. It could involve a multidisciplinary team of multiple people, such as social workers, community health workers, palliative care team members, And then there are multiple ways in which the feedback loop can close, depending on the input. So you could have just ongoing remote monitoring if the patient is stable, if there's no issues identified. If an issue is identified, they could be scheduled for an early visit, or treatment change could be recommended remotely followed by an early visit, or the patient could be referred for a full review to visit the hospital. So the time frame can be immediate, and that could be seen in the setting of an app, for example, with an immediate feedback loop on the phone, or it could be minutes to hours, or it could be variable, may take days if there's a multidisciplinary team involved. So it's very heterogeneous. And depends on multiple systems, but primarily there are 4 ways in which a feedback loop could function. So this is the 5 components of a connected care loop. And for anything to have meaningful change to the patient, it has to at least satisfy or be or have at least a functioning 5 points. And so there has to be a patient signal, there has to be a threshold onto which to act if there's an abnormality. There has to be a named clinical owner. There has to be someone responsible to act on the problem if a problem is detected. And there has to be an action as to what happens next if you've detected something. So, for example, if AF has been detected. And then the most important part of the system is the feedback or quality audit loop. How is the system operating? Is it overanalyzing, underanalyzing? And so these 5 components have to be operational and present for a system to lead to meaningful clinical outcomes. And so when I first looked at this topic, I kind of separated the major domains, and the 4 major domains or themes that came up was heart failure telemedicine. So that could involve just simple things like weight, blood pressure, symptoms, using structured questionnaires where it's fed to a team, and then the team can act upon it via remote consultations. There is the more advanced pressure-guided heart failure cares using implantable hemodynamic monitors, which could be CardioMIMS, which is a pulmonary artery implantable monitor, or a monitor implanted in the left atrium for left atrial pressure. Then there's the implanted device follow-up. So using the data from implantable pacemakers or other devices where multiple parameters could be analyzed and heart failure admissions could be predicted. And then finally, using wearable technologies where devices such as Fitbit or the Apple Watch could detect atrial fibrillation. And the table at the bottom shows you the possible things that could be collected. There are non-invasive variables, simple things like pulse, blood pressure, body weight, blood sugar levels, oxygen saturations. And then there are more technologically advanced variables such as pulmonary artery pressure, left atrial pressure, impedance, and detection of life-threatening arrhythmias, primarily from implantable devices. So does monitoring change care? And so as we discussed earlier, if you capture a signal, there has to be an action followed by a meaningful change in outcome. Otherwise, what's the point of doing all this if there's no meaningful outcome? So a common theme to all these technologies is anything meaningful going to change for the patient? And so, for example, in heart failure monitoring, and we'll touch on this trial later, a meta-analysis showed that if you combine early telemonitoring with an actionable outcome, in fact, cardiovascular mortality is reduced with a relative risk of 0.83, and heart failure hospitalization is also reduced with a relative risk of 0.71. And then there are other operational models where, for example, it's led to fewer visits because things were looked at and picked up early, and the final box at the right shows you that just because you detect something and you implement treatment, it doesn't necessarily always mean it will translate into meaningful change. And a good example of that is the loop study, which looked at implantable loop recorders to detect AF. Detection followed by anticoagulation did not amount to a reduction in stroke. So I'm going to focus on heart failure now. So this is a meta-analysis published in 2022 by Lancet Digital Health that looked at how heart failure telemedicine can improve outcome. And the important idea out of this meta-analysis is it only improved cardiovascular mortality and reduced cardiovascular hospitalization when it was combined with clinical contact. So there has to be some form of contact. Monitoring alone didn't do anything. There has to be monitoring plus a structured response. So the loop has to close. And there was a meaningful effects. And as you can see here, predominantly involving cardiovascular mortality and cardiovascular hospitalization. This is another meta-analysis that looked at a similar thing. Again, heart failure telemonitoring confirms, again, works when someone acts. So you can see there was a reduction in all-cause mortality, 0.84. There was a reduction in first heart failure hospitalization and total heart failure hospitalizations. And so these two seminal meta-analyses showed that in terms of heart failure patients, if you institute early monitoring in the vulnerable phase, immediately post-discharge, and have a structured a team to act upon it, you will have a meaningful response. This is the invasive device that monitors pulmonary artery pressure. It's called CardioMIMS, and it was investigated in two trials. Basically, it's a pulmonary artery sensor. It establishes a baseline and then continuously monitors several hemodynamics. And based on those hemodynamics, the data is reviewed by a doctor or a technician. Therapy is adjusted, and the adjustment could be in the form of diuretics or vasodilators as needed. So the patients selected to undergo this procedure were heart failure patients that had class 3 symptoms with recent hospitalizations. And the hypothesis was that pulmonary artery pressure rises 1 to 2 weeks before clinical decompensation. So using this implantable device, you could preempt the decompensation and institute preemptive intervention. The benefit requires that someone acts on the data and adjusts therapy within 24 to 72 hours. Otherwise, the whole premise doesn't work. The whole point is to preempt decompensation and institute therapy early. So the Champion trial looked at patients with class 3 heart failure and who had this device implanted. And as you can see, heart failure hospitalization was reduced at 6 months, and also over randomized follow-up, and that translated into 37% reduction in heart failure hospitalization over the entire randomized follow-up period. But this is an expensive, invasive device. Guide AF also looked at the same device, although slightly the inclusion criteria were slightly less sick than the previous cohort. However, this and Guide HF, a big portion of the trial occurred during COVID, and so it was a neutral trial, maybe because of the reduced efficiency of healthcare systems during that time that may have attenuated the positive effect. And so the overall trial was neutral. However, when a pre-specified subgroup analysis of the pre-COVID subgroup was looked at, there was a signal to a reduction in the primary endpoint with a hazard ratio of 0.81 and a p-value of 0.049, suggesting there's probably an interaction with the dynamics of the healthcare system during that time. Going to be moving on quickly to other heart failure interventions. This trial looked at a system in which the staff, the telemedical service that responded to home monitoring device bundle, which involved multiple parameters, such as ECG, blood pressure, weights, symptom questionnaire. There was a 24-hour staffed center with an algorithmic triage, and essentially it reduced days. They looked at days lost due to heart failure hospitalization, and that was significant in the sense that it reduced the number of days per year, per patient year, lost due to hospitalization. I'm going to quickly, for the sake of time, go through the rest. Hermes was another trial that looked at telemonitoring plus intervention in heart failure patients, and it used the mHealth app, which collected several inputs, plus a specific algorithmic team that interacted with the patient and the app. And again, this shows that the primary event was reduced in terms of relative risk reduction of cardiovascular death, worsening heart failure with patients who were vulnerable in the immediate post-discharge phase that used the mHealth application. These two trials, I'm going to briefly skip on them, basically just looked at analyzing data from implantable devices. There was no action loop, and hence just looking at the data did not amount to anything meaningful. I'm going to move next to wearable AF detection for the sake of time. And so the premise here, again, is if you're going to detect something, there has to be a way to pick it up, act on it, and there has to be a meaningful response. So in the case of atrial fibrillation, if you pick up atrial fibrillation earlier, you institute anticoagulation safely and earlier, and that should translate into less stroke. What remains proven, what is proven at the moment, wearable devices are excellent in picking up atrial fibrillation. However, what remains still unknown to this day is whether or not there will be a reduction in clinically meaningful stroke. The important study that looked at that was the LOOP trial, and it showed there was no significant reduction in stroke with this method. Okay, so this is a meta-analysis that looks at the accuracy of wearable devices in terms of AF detection, and as you can see, it's great. The sensitivity is 95%, specificity is 97%. So yes, the devices are good at picking up atrial fibrillation.
Dr. Amir, can you summarize in next 30 seconds?
Yeah, so almost done. So the Apple Heart study, just briefly, I'm going to touch on this. There was about 500,000 people enrolled. Interestingly, this looked at atrial fibrillation. Only 0.5% received an irregular heartbeat notification rate, but the yield wasn't bad, actually. So of these patients, when the ECGs were looked at, so if they had atrial fibrillation, and 34% of them had atrial fibrillation. I'm going to skip for the sake of time and finish my talk with this. This was the LOOP study that looked at implanting loop recorders and looking at AF and anticoagulation. Yes, more AF was picked up. Yes, more people were anticoagulated, but unfortunately, it didn't translate to reduced stroke or systemic embolism. Thank you for your time.
Thank you, Dr. Amir, for a wonderful talk on wearables. And it's going to change in coming time because almost 70–80% of our patients are using these wearables, and they come to your clinic every day asking, my heart rate variability is this, my warning is this, what shall we do? So we should be aware of all these things. So we'll invite the next talk.
Go ahead. I think end of session. Yeah. So it's my pleasure to invite Dr. Rajiv Lochan, who is a consultant intervention cardiologist and one of the most senior intervention cardiologists in the country from Al Zahra Hospital, Dubai, to speak to us on tough calls in ACS.
First of all, thank you very much, chairpersons and friends. As usual, Brajesh has been very instrumental in keeping this academics going, and his meetings have been very, very educative. So I'm going to talk a little bit on the practical aspect of some cases which we handle or which we face problems when we are doing some interventions. So maybe part of this, my job has been done by Dr. Gupta, and he's mentioned some few important points which will relate to some of the cases which I present. So my talk is not on theory, it's just on the few cases which I have seen and how one should manage. That will be my advice or my way of treating them. So let's go to case number one. It's a 36-year-old or young Britisher presented in emergency room after a chest pain, and it was lasting for 30 minutes with some sweating, and he was brought in by his friend in his car to the hospital. While in the car, he blacked out a couple of times, and when he reached an emergency room, he again collapsed in front of the medical team, and which required CPR, and they realized that patient was having episodes of ventricular tachycardia, degenerating into the ventricular fibrillation and cardiac arrest. So that was the scenario, and this was interesting. It was happened luckily at about 9 or 8:30 in the morning when most of the hospital staff was entering, and the same time the patient was entered, so they just been taking a good care at the same time. The fresh staff was there. So the status of this patient in ICU, rhythm reasonably stable after antiarrhythmics like amiodarone infusion. ECG showed ST elevation, anterior wall myocardial infarction. Ventilation was established with sedation. Persistent hypotension was continued, and that was a worry how to manage in spite of inotropes. So the added treatment was intra-aortic balloon pump, and intra-aortic balloon pump stabilized the hemodynamics, and the patient was continued on that. This was one of the ECGs during the monitor. You can see that patient was having sinus rhythm in between, and then it was changing into the ventricular fibrillation, and that was its happening. And when it was persistent, they did a DC shock multiple times. Post-stabilization, this was the ECG. Very horrible looking ST elevation, markedly elevated with ST elevation and T waves, and suggestive of various anterior wall infarction or anterolateral infarction. So invasive management choice was whether to thrombolize and give a conservative management, but as you know, after multiple CPR attempts, thrombolysis sometimes could be tricky, and so it was taken as a delayed primary PCI, and management was done with the help of intra-aortic balloon pump, which was initiated as soon as possible to combat the hemodynamics, which really improved with the intra-aortic balloon pump, although there are some contradictory data in the literature which suggests that IIBP is a useless device. In one of the European meetings, they suggest that, but again, you should have one kind of support device which you are familiar with and which you can apply, and you can apply in time, because most of the patients in the shock trial, it was applied very late. So coronary angiography showed proximal LAD total block, and as simple treatment, the patient was taken with balloon angioplasty and stent placement, and that image, this is the angiogram which opened up quickly, and that showed dramatic change in ECG. After a few hours, ECG showed marked ST depression, and this is actually a subsequent day ECG, and there was, of course, QS pattern in anterior leads, but a patient was stabilized and all support was removed and IABP extubated, and in fact, the success of this patient, I believe, is because of the primary PCI or the acutely blocked artery, and it was a follow-up was excellent. This patient, we used to come with follow-up in my clinic for years, and he was jogging 3-4 kilometers with a massive heart attack, anterior by large infarct and recovery. So this is what can happen if you treat patient early, and this one of the examples. Second patient is MI presented with cardiac arrest. This is a 49 years Asian male, developed severe unbearable chest pain and sweating while he was at work. So one of his colleagues, they just try to do whatever they can, and they quickly put him in the car and brought him to the hospital. While he was being driven to the hospital, in the car he fainted a couple of times, but just outside the hospital, he collapsed and he did not respond. But it was just only 1 minute away from the hospital. An emergency room CPR was initiated. ECG monitor showed VF, DC shock and epinephrine as usual treatment was given. His later on heart rate come to 50, and with wide QRS, with this was secondary to all the insult which he has and biochemical changes in the system. It was just like interventricular conduction defect. There are no P waves, so you can call it as a junctional rhythm with various effect on the rhythm. And obviously he was put on ventilator. This was the scene. If you can see, a lot of people are working on him. Ventilation, somebody CPR and maintaining lines, medication, and ECG as you look, horrible ventricular fibrillation going and coming time to time, and this was this. And this is the ECG after he was stabilized. After stabilized, relatively stabilized, because his BP was still low and he was on heavy dose of inotropes. But this rhythm, the ECG does not show any classical ST elevation, but it does show significant abnormality. With adrenaline, epinephrine, it showed increased in heart rate and blood pressure, so he could be stabilized to shift to cath lab. So urgent invasive management was done, temporary pacemaker and coronary angiography, ostial total block of LAD and insignificant disease in RCA. Urgent PCI was done. Hypertension was continued. This is the ECG angiogram. You can see in the first picture that there's a complete block. On the right picture, it shows the completely opened artery with balloon and stent. Interestingly, next day ECG, no Q waves, and all patient was fully recovered. So it tells us the time which the patient was treated, because he was outside collapsed and within minutes he was resuscitated, but it took still more than an hour, hour and a half to take him to the cath lab, but still patient showed significant improvement. In fact, his ejection fraction was 55% on discharge, and it shows anterior wall mild hypokinesia. So message is time is money. Early opening of the artery was the key to almost full recovery. In ACC guidelines, immediate angiography and PCI, when indicated, should be performed in resuscitated out-of-hospital cardiac arrest patients. Case 3. This is I would say, escape sudden cardiac death probably, or cardiac arrest. This is a patient who has about 55 years. He was brought into emergency room with a history of transient blackout while he was driving on Sheikh Zayed Road. And his co-passenger took the control of the car, and when he fainted on the wheel, and it was brought by the side on the halt shoulder, and then he was brought in by emergency for this ambulance. He passed out again in emergency with pulse rate of less than 30 per minute, and BP was not recordable. CPR, as usual, conducted, and intravenous epinephrine was given, and patient was transferred to the cath lab. This was the ECG was showing multiple episodes of ventricular tachycardia and bradycardia, and again, he was given a temporary pacemaker to stabilize the rate, and IBP has to be done because the patient was not stable. Angiography was horrible. LAD was totally blocked, circumflex was totally blocked, chronic total blockage, and he has right coronary was also blocked because he has a thrombotic, and that seems to be culprit region. But patent, he had a large ramus intermedius artery, which I would say was the lifeline to keep him alive up to the lab. And this was the case. Interestingly, this case I have seen 6 years before when he was advised to have bypass surgery. He did not agree on that, but he carried on and this happened. At that time, we also noticed multivessel disease. So this was the left picture shows the complete or almost complete thrombotic occlusion of the right artery, which is opened up with angioplasty. So primary PCI in cardiogenic shock is a class 1 indication and should be offered if suitable as invasive therapy. Hemodynamic support is useful as adjuvant. Whichever you are comfortable with should be used. Culprit artery or complete multivessel angioplasty is debatable, but we will go a little bit later on this. Case 4, 56 years male, presented him epigastric pain. And his risk factors are hypertension. He's a very, very fit guy, regularly walks 4 or 5 kilometers, very low fat diet. EC showed anterior wall MI. And while he has got a high dose of statin was given and lipids target was kept less than 55 LDL. Echo anterior wall akinesia and EF was 35%. And this was his ECG in emergency room while he just actually drove into the hospital and his ECG. And he's lucky that he did not have this ECG at that time. So anterior wall MI, and he resumed a regular walk and everything. And his 1 year experience, again, recurrence of episodes of angina, and angiogram showed 99% stenosis of proximal LCX artery. So his LDL was quite low, but what was wrong was one of the factors wrong, which was the lipoprotein little a was found very high, and his total cholesterol was brought down to 123 and LDL was 47. In spite of that, he has it. So we don't know what to do in this situation. A lot of trials are going on, as Dr. Gupta has mentioned some of them, and small interfering RNA therapy or zilebesiran could be useful, but still the data is very limited and we don't have any endpoint benefit data yet. Second thing was the inflammation, whether it was the marker why he has a recurrence in spite of other good improvement. And chloroquine can be used, and there are some data and few trials which have shown effectively. So that was added, these two things. So what I have learned from these tough cases in the patient, what is the common in these patients? All these patients use personal car for reaching the hospital on the onset of ACS symptoms. Use of an ambulance should be taught to all of our patients who are healthy even. All the population, our friends, we should tell them they should use the ambulance, because if they arrest in the car or transportation, this is very, very dissatisfying, and most of the ambulances have a means to protect them. Hemodynamics to be stabilized prior to the high-risk PCI. Support should be used, whatever is you are comfortable with or whatever your team is comfortable with. If you use something like Impella, which you have rarely used, and you have to collect and assemble and get everything in place, so that might take longer. So time is very important in this type of cases. Complete revascularization or culprit artery. So culprit artery should be done and then see if the patient is stabilized. You can always stage the procedure to improve the outcome, immediate outcome and long-term outcome. Case 5 is a 48 years male presented with severely limiting exertional angina over 3 weeks. Post-myocardial medical history shows PCI in inferior wall STEMI 8 months ago, and he has a recurrence of symptoms. And we did an angiogram which showed left main distal 95% stenosis extending into the circumflex artery. So this was very horrifying. Within a very short span, this gentleman came back. And if you look at the picture on the left upper one, proximal LAD has a significant block, and which was seen and has been done angioplasty, keeping both the wires in LAD and circumflex. And this time the stent was kept from left main to, next one. Sorry, what is the next? I'm going, backward, yeah. So this was the result which we have at multiple steps. I will not go in detail because of the paucity of time, but finally good outcome was obtained. Left main was opened up. I will skip the cases because I think of the shortage of time. So this was just, I'll show the picture of another patient who had a severe block in the left artery, left main artery, and really almost disconnected left main. But he was taken care with staged angioplasty and he did very well. And he's still following up after a couple of years. So I would suggest that these patients which are tough, they should be handled individually, tailor-made plan of treatment. I would just come back to this one. So the treatment planning in each case should be done on individual basis. First and foremost important is hemodynamic stability, and multivessel or left main equivalent lesion have to be carefully handled. Intensivists are useful to have in your cath lab with you, and they can stabilize BP and inotropic support and ventilatory support when you can concentrate on intervention and the support of the artery circulation. IABP and impella support are useful depending upon whatever you're familiar with. Culprit vessel only approach is practical. With stage intervention is useful in reducing complication and increasing the success of the treatment. Thank you for this gentleman, Andreas Grunzig, who has been father of angioplasty, who taught us, who started the first angioplasty, and we are following his path and treating our patients.
Thank you, Dr. Rajiv Lochan, for eye-opening cases and saving 5 lives and many more. And the floor is now open for discussion and questions for 5 minutes. And because of short time, so we will try to summarize. So Dr. Gupta will like to start some question he was asking. Yes, Dr. Gupta.
Thank you very much. I have a question. Sorry, Dr. Gupta, I missed your talk. I have a question for the second speaker. And Dr. Amar, he's here. So,
yeah.
So my question is that how short episode atrial fibrillation you think is worthy from the clinical point of view to consider anticoagulation in a patient whose chest goes on the higher side? Like for example, a wearable device shows 30 seconds, shows 20 seconds. I mean, what time with the significance or even 5 seconds is enough?
This question to be answered by Dr. Amir, I believe, from Connected Cardiology.
Yes.
Dr. Amir is here? No. So anybody wants to take this?
So Dr. Amrish
is here. Dr. Srinivas will answer.
See, it is still debatable, and whatever the data we have got from 60 seconds to 3 hours. But as per ESC guidelines, it should be at least beyond 3 hours. Before that, we don't have a definite data that it has got any significant beneficial effect. So debate is still open.
It also depends upon Chadwell's score, what is milieu in which it is happening. Suppose patient has already documented disease, then even one episode you feel could be a problem, then you could start early. But as sir said, the cutoff time is taken in 3 hours. Patient has a hugely dilated atria, LV dysfunction, heart failure already, where it's likely to recur. That's where as a clinician we use our judgment and try to start at least a small dose of anticoagulation. One other point, congratulations Dr. Lochan sir for sharing excellent cases, but I want to just highlight the hall here that whatever amount of inotropes, some critical care doctors, they don't, I'm not saying everybody, some of them, they want to push inotropes and they don't get the patient to right time to the hospital for revascularization. How much ever inotropes you pump in. We have seen many cases where just opening the artery, suddenly pressures pick up. So revascularization is most important. Try to get him to the place where revascularization is available. So without that, how much ever inotropes you pump, still the patients will maintain low pressures. And if it gets delayed, then he goes to acidosis and all that secondary effects of acidosis, the cardiac suppression starts. try to get to the hospital as soon as possible, try to send him for revascularization. So once the artery is open, the inotropic requirements decrease, ECG improves, everything dramatically improves. So that thing should be kept in mind. Once revascularization is done, that's a mantra for patients to improve.
Thank you.
I mean, the biggest improvement in the ischemic care occurred because of the improvement or the care of the ventricular arrhythmias which occurred in the first 1 hour of the myocardial infarction. And Dr. Lochen's all the cases highlighted this point that the arrhythmias, the important component, is harbinger of death because of the sudden occlusion of coronary artery. And like Dr. Srinivas said, here the pathophysiology is occlusion of the artery, and the myocardium without a non-perfused myocardium will not increase contractility, whatever inotropy will give it. So obviously the key is to open the artery.
So I just want to ask Dr. Lochen one question. So how stable, I mean, we tend to say, okay, let's stabilize the patient a bit before we take up to the cath lab. But we, at least in our practice, we take highly unstable patients with probably during CPR at times, also from the ER to the cath lab. So what would your thoughts be on that?
I think this is a challenge, and it depends how much blood pressure you have yourself. If your blood pressure is all right to handle, if you are strong enough, you feel that you will manage the patient and bring him alive. So that's the thing that depends on your experience and the way you have handled in the past. We all learn from our experiences. And I remember the days when we were with Dr. Brajesh in India, and at that time we were very primitive in doing angioplasties, and we were taking tough cases even at that time. And it does happen. So there is no set number of blood pressure where I take the patient. Where I expect that patient, we will be able to open. If suppose the clear history of infarction, chest pain, I'm sure that it's and for example, LAD. So most likely if you open the artery, you will be able to bring him back. So this is the most important. And you keep on supporting whatever it, and one of the patient, as I see, a triple vessel disease, and his right artery was blocked, also third artery, and that his heart rate was 30. So obviously we have to put a pacemaker and stabilize. So that was the thing that stabilized the blood pressure in addition to inotropes. So that's the thing. And as Dr. Srinivas said, the most important thing is the revascularization. So sooner you do it, quicker it is, and better is the result. And I think there is no set word. Each patient will have a difference.
Good, thank you. So very last comment before we close.
One word about surgery in acute MI. I think our surgical colleagues also hate if you send a patient of acute MI to surgery, antiplatelets given, a lot of bleeding, in trouble. And by the time surgeon arranges everything, the important time is lost and the myocardium gets damaged. So what is practiced in all the centers, I think across, I think you should also agree, is to revascularize the culprit vessel at least immediately. Even if a patient has a surgical disease, don't directly push him for surgery because the important time is lost and by the time everything is done. So in all the centers now it is established that you do a culprit vessel PCI, do revascularization in time. Then later on, once the patient stabilizes, you can decide whether he wants to go at a staged PCI or surgery, depending upon whether it is left main disease, other things. But the message is avoid surgery in the acute MI stage unless there is a mechanical complication. The only place where surgeon comes into picture in acute MI is where there is a VSD or severe metal regurgitation, things like that, where it independently warrants surgery. That's a different story, leading to shock. But otherwise, avoid sending patients in acute stage to surgery and do revascularization. Then stage-wise, once the patient is stabilized, you can decide what to do.
Thank you so much. So can you conclude, Dr. Mishra? We are slightly behind the time, but we'll try to catch up.
Hello. So thank you all the speakers for bringing out the new chapters and guidelines and ideas which we are going to discuss over the tea and coffee break. If there is some further questions remains or some questions there in the mind. And we will go to the second session, and I will invite Dr. Prophet Dr. Brajesh to carry out.
Good morning once again, and there are lots of audience now. I am very happy to see all you in the morning. And with this, we are closing the first session. I want to give you some heads up about today's plan and program. The session runs until 6:30. After this session, there will be a coffee break of 30 minutes. The coffee break is in the next room on your right side and my left side. That is room B, hall B. There are also the sponsors kiosk in hall B, and some sponsors kiosks are outside this hall. So there is a pre-function area as well as there is dedicated hall B. The coffee will be available rest of the day, all the time, any time, but the break will be between 11 to 11:30. When you enter in the session, please do not forget to get your selfie scanned. And when you exit at the end of the session, also do that. The other thing is there are some complimentary bags available for all the registrants. If you have not collected, you can please have your bag. That is a gym bag. So this time tried a different approach, not a laptop bag. Enough studies, but it is for the gym goers. So the idea and theme was different. And before I invite for the next session, we would like to felicitate the faculty of the first session. So very quickly, please, I request you all to please come up, Dr. P.K. Gupta, Dr. Lochan, all the moderators and all the speakers. So Dr. P.K. Gupta. Dr. Azad Moopen. Yours is to the speakers. You are also a speaker, so it is in the afternoon session. They plan like this. Dr. Georgie Coach. Now. And may I invite the chairpersons for the next session, Dr. Srinivas Kumar. Dr. Srinivas Kumar is a very prolific interventionist and structural heart interventionist in particular from Hyderabad, India. And we are very happy to have him with us. He has flown all the way back from India. Dr. Srinivas. Dr. Ajit Jain is a cardiothoracic surgeon from Delhi, and he's a very regular attendee of our conference. Dr. Samir Diwale, also a cardiac surgeon. So you can see the flavor of this session is more towards cardiac surgery, and structural heart. And with this, I leave the floor upon you with the sincere request that you have maximum 55 minutes to wind it up. Thank you.
Yeah, morning friends. I think after an interesting session in the morning where he highlighted acute coronary syndromes and the role of revascularization and role of telemedicine devices after that. I think now we'll go on to another interesting. Sir labeled it as beyond coronaries. Obviously, there are valves, there are pulmonary thromboembolism. Some of the talks will be discussed. The first will be my surgical colleague on talking on surgical indications in infective endocarditis. I thought you'll discuss on SAVR versus TAVR, but I think it's already decided that TAVR works. So I think Dr. Gopal Bhatnakar, the chairman, Heart, Vascular and Thoracic Institute in Cleveland Clinic, Abu Dhabi, will be speaking on surgical indications in infective endocarditis. Over to you, sir.
Thank you very much for that kind introduction, and welcome, colleagues and guests. In fact, it was supposed to be on SAVR and TAVR, and the fault is mine. My office uploaded this instead of, I had 3 or 4 talks that were to be uploaded, and they uploaded this one, so I apologize to the... Now, I can make a brief comment, of course, and we can have further discussion in TAVR versus SAVR. So, I think you can summarize the current state to say that anybody over the age of 70 at our institution, at the Cleveland Clinic, and in most places, the primary intention to treat should be percutaneous. Unless there's endocarditis, some other high-risk factor involved, the TAVI or TAVR works brilliantly in these patients and even in the low-risk patients. In those patients that are below 70, let's say the equipoise is around 65, then the heart team discussion should take place. Again, for patients that are very high-risk surgical, with high surgical comorbidities, then we would, of course, in that discussion, perhaps go towards TAVR. But with those younger patients, a decision also has to be made regarding the type of prostheses. At current, even though we have a bias against mechanical prostheses, and most of our patients are receiving bioprosthetic valves, if you actually look at the background data, mechanical valves at 8 years and 10 years still have a better survival in younger patients than bioprosthetic valves. And that population, that is against, that sort of is against our bias, but that's the pure literature. So, there are some socioeconomic imperatives around anticoagulation, but all things given in a frank discussion with the patient, if they choose to have a mechanical valve, then in the younger patients, it's certainly obvious what to do. We also have surgically other alternatives, such as the Ross procedure and homografts, that can be available depending on the jurisdiction. So I know we can certainly address the TAVR versus SAVR, but in my mind, patients over the age of 70, they all go with the intention to treat for percutaneous. Now, I will try and take my remaining time to cover over surgical endocarditis. What should the cardiologist know? Well, let me see if I can actually work. The burden and scope of infective endocarditis. The early mortality in these patients is 15 to 25%. Very often, the presentation is delayed. About 50% of the patients that you see initially, whether they come through medical service, cardiology service, and they can present a wide variety of different ways, about 50% will end up requiring surgery. And very importantly, and part of my presentation will emphasize what to do with those patients that have had or are high risk for neurological events, which is about 20 to 40%. If you take a look at mitral valve endocarditis and you do MRIs on patients that are presenting, about 40% will have abnormal MRI findings. 3 pillars of surgical indication. Patients have heart failure, mitral regurgitation, severe aortic insufficiency. That needs to be considered. There's anatomic considerations such as fistulization, uncontrolled infection. Despite the current state of antibiotics, surprisingly, there's still people that we cannot control their infective burden. Fungal endocarditis is a special, and I've never actually seen a patient survive a fungal endocarditis. You can do the surgery, but they're so immunocompromised, they generally do not survive. Of course, and then we'll discuss the embolic risks. Surgical timing of endocarditis, European Society guidelines, emergency is considered within 24 hours. Patients have shock from acute regurgitation, obstruction, or fistulization. If they have a mechanical problem, generally no amount of vasopressor support can really correct that mechanical problem. We have had patients we place on ECMO, to try and support them until surgery. And once ECMO support is established for mitral or aortic endocarditis, then it does buy you some time to resuscitate the body. Remember, ECMO will resuscitate your liver, your organs, but if you have severe AI, then it's actually really blows out the heart. So while it may give you temporary short-lived support, you need to move on very quickly. Those patients that are urgent, severe heart failure, vegetation is greater than 10 millimeters. And then there's the non-urgent patients. They present with prosthetic valve endocarditis within 6 months of implants, usually Staph aureus. You want to get them treated. It's more complex redo, and they can kind of wait until things settled. I'm going to break it down, try to the 3 major valves we operate on: aortic valve endocarditis, mitral, and then tricuspid. So if you take a look at aortic valve endocarditis, this little schemata on the side here reflects really what would be looking at from a surgeon's point of view. You're standing on the right side of the table, and we are seeing this view here. This is a case where we actually explanting a core valve. The cross clamp is up here, feet are here. That's my hand, and then we're carefully dissecting out. This valve was infected, and then you'll see the right corner here, the left corner, just to orient yourselves there. Heart failure indication. So again, once again, emergency, acute, severe regurgitations, poorly tolerated. We have obstruction that can be causing refractory pulmonary edema or cardiogenic shock. Urgent, 3 to 5 days. Again, the severe aortic regurgitation or stenosis where heart failure can be controlled. If you have aortic fistulization into a chamber, usually leading to a shunt, usually it's the right atrium. We want to be able to work those patients up and get them. And there are less, and then you can wait. Even if patients have severe aortic regurgitation, if there's not any gross evidence of heart failure, then it's best to get those patients treated, and they can be operated on a more elective basis. When there's uncontrolled infection, 3 to 5 days, it could be uncontrolled root abscess, pseudoaneurysm, or I find a new conduction abnormality. As we all know, the worst thing to see is this prolonging PR interval. You suddenly will get a heart block, and that's just evidence that the infection is eating in to the septum. Endocarditis surgery is most challenging because the local destruction of tissue makes this is technically more difficult. The more is destroyed, the more technically difficult is the procedure. Vegetation in size, of course, as we know, is a strict indication. There's a slight difference between the ACC and the European guidelines, which any vegetation in the European guidelines exceeding 30 millimeters is an absolute indication, is an indication for surgery. And it's also important to remember that the embolic events occur the highest risk is in the first 2 weeks. So if we see people with chronic vegetations that are 10, 12, 15 millimeters, patients otherwise debilitated or not ready for surgery, then they're not as high a risk as they are if they acutely present with surgery. On the American College guidelines, again, mobile vegetation is greater than 10 millimeters, indication for surgery regardless of severity. The annualized risk of embolic phenomena of a 10 millimeter vegetation is around 15% over a year. So again, highest in the first 2 years. Prosthetic valve endocarditis is a very specific, different creature, and it is very high risk. You have to take out the prostheses, you have to clean up, and very often the presentation is delayed. The surgical mortality can approach 20 to 40%. And so, we make every effort to try and optimize these patients. So emergent surgery, prosthetic heart valve, endocarditis with heart failure. There's usually severe prosthetic valve dysfunction on top of that, either it be acute AI or most likely there's something wrong with that valve to begin with. It's often an aortic valve may be chronically stenotic. Staph aureus, again, is a very aggressive organism. Staph aureus, you cannot wait too long on, and that's one of my personal indications to move ahead with surgery a bit quicker. Prosthetic valve endocarditis early is within 6 months, is assumed to be contamination at the time of implant, and you need to complete debridement and again, a valve replacement. Mitral valve endocarditis. Here you have the consideration between valve repair or replacement. This is a recent patient that we have. Just again, the schematic orients you to where we are. And I have here, again, the same thing. This giant thing is just a vegetation. This patient actually came to the OR in refractory shock. He was on VV ECMO because his lungs had massive pulmonary edema and we tried to treat him for several days to see if we could get him out of pulmonary edema because that's a terrible problem with cardiopulmonary bypass. Nevertheless, we're not able to get, so we did end up operating on him emergently. This is just all giant vegetation here. The entire mitral valve is destroyed. This is the opening. This is the left atrium is open here. We ended up, he was a young man. Nevertheless, I put a bioprosthetic valve in because I knew he was going to require ECMO support post-operatively. And he's slowly recovering now from that. The problem with ECMO and prosthetic valves is the risk of thrombosis of them. So, his survival is probably somewhat limited anyways. So we have, again, the same indications, very much severe acute mitral regurgitation. It does respond quite well to an intra-aortic balloon pump, and you can stabilize patients, valve obstruction with giant fungal balls, of course. And if there's severe regurgitation, but the heart failure symptoms are controllable, then we can wait a little bit longer. Local uncontrolled infection is a real problem with mitral endocarditis because they'll eat into the septum, and replacing the valve then becomes difficult. Is a higher risk of dehiscence of the valve. We've got persistent bacteremia, 5 to 7 days despite adequate antibiotics. Again, the same 10 millimeter size for vegetations is there. Now, we have the option to repair a mitral valve. About 40 to 80% of mitral valve endocarditis patients can be repaired. If you can actually wait a patient out, give them antibiotics, treat them, so the longer they are out from the surgery, more the repairable the valve will become, because the valve will, get a fibrosis of the valve. Very often, if you try and operate acutely for a perforation, it's not only the area of the perforation, but the surrounding area is quite inflamed and difficult to deal with. It may be self-selecting, but if you are able to perform a repair, the results are better in terms of mortality. But of course, there is a pre-selection bias for that. Favoring replacement if you have extensive annular destruction, abscess, fistula into other locations, or if you're operating with very acutely, you end up having to replace the valve. Of course, if they have a previous prosthetic valve in place, you're going to have to replace. Tricuspid valve endocarditis. Now, these are two different factors in here. Again, the schemata that the surgeon sees, I've set up there. When you open up that right atrium, this you'll see this aspect. This is a patient that actually had a tricuspid mechanical valve, which is unusual, done. And we remove. Indications for surgery: right heart failure secondary to severe tricuspid regurgitation, poor response to diuretic therapy. We try and minimize minimize operating on tricuspid valve endocarditis. They're very sick patients, very often, regardless of jurisdiction, especially, but more predominantly in Western jurisdictions, is related to intravenous drug abuse, and the relapse rates for that. So you put a prosthetic valve in them, they'll come back. I think in my own personal record is having to do a patient 5 times in 3 years for recurrent endocarditis. They present very large vegetations. In addition, many patients will now have significant pulmonary emboli and pulmonary abscesses. And there's sepsis. You have to, although you may be feeling, you're pushed to operate because of sepsis, very often the sepsis is not from the tricuspid valve. It's from the multiple pulmonary abscesses, and you just have to persist. Very often people, the infectious disease specialists or the intensivist may be pushing you to operate or intervene on the valve, and just be patient with that. Continue antibiotics, even though the patient is sick. So my surgical approach, of course, repair is better than replacement in the tricuspid valve, especially in patients with whose etiology is intravenous drug use. And even if you leave moderate regurgitation and they're able to get by, it's satisfactory. There are programs, especially when there's heavy drug abuse involved, that we just excise the tricuspid valve, leave the patient with wide open TR, and see if they tolerate it. And remembering that the outcomes of IV drug abusers, the average life expectancy of somebody who presents with IV drug abuse is only 3 years. So it itself is a very malignant disease. Most people are not, even if you put them in rehab, they relapse. The other aspects, so you have the IVD, the intravenous drug use patients, Staph aureus is predominant. It's going to be right-sided. Often they present late and with pulmonary, septic pulmonary emboli and large vegetations. 40% of these patients will just relapse to their drug use, so that has to be considered in there. Then there are, of course, the patients that have right-sided catheters, dialysis, those sorts of things. Different patients, they also are very sick from their preoperative comorbidities. And so pacemaker lead extractions can be done. Most of these extractions can be done percutaneously. Now, unless there's some large vegetations, we'll go in and do surgery. If it can't, then and they have massive tricuspid endocarditis, do the surgery, remove the leads. Now, I preferentially then will place epicardial leads on them to try and prevent the need for more intravascular hardware. Neurological complications, I just will run through this briefly. So ischemic stroke, 60 to 70 patients will have this when they come in. If they're just hicked up, you generally do not have to delay surgery unless there is significant damage. If they have hemorrhagic stroke, it's best to delay. Silent cerebral ischemia, as I said, will occur very often. Surgery does not need to be delayed for that. If patients have a myocardial aneurysm, we should treat the aneurysm first before and then coordinate surgery. If they have meningitis, brain abscess, surgery does not need to be delayed. I'll skip this because I see that time is up. Myocardial aneurysms, this really can be coiled or they can be treated, and you re-image them in 5 to 7 days. Sometimes they will, quote, dry up. So generally speaking, I would, for minor, all patients should have an MRI, CT scan, and CT angio of their brain. Depending on the results of that, myocardial aneurysm should be treated. If they have a large ischemic stroke, and then it can be delayed. If it's a small ischemic stroke, the risk of hemorrhagic conversion is small. You can proceed with surgery based on the patient's indications. If they have large hemorrhagic stroke, then that should be delayed 4 weeks, where they will achieve a baseline risk of a stroke. Multidisciplinary team mandate. Obviously, our cardiology colleagues, surgeons, infectious disease, everybody needs to be involved in treating this patient. Despite that, you can see that this is a high-risk surgery, that isolated aortic valve replacement still has about an 8% mortality. When you do prosthetic valve redos, 20% and higher. Independent predictors of mortality, sicker patients, sicker, worse outcome. I won't review that, a few references, and I thank you very much for your attention.
I'm inviting Dr. H. Srinivas Kumar. He is the founder director, Facts Foundation and TCT India, Chairman, Cardiac Sciences, Apollo, Hyderabad. He is going to deliver his talk on TAVI and MitraClip, setting the new trends in valve therapies.
Morning, friends. Morning, friends. Thank you, Dr. Brajesh sir, for the opportunity. As you very well know now, that as already told by cardiac surgeon, there's a lot of scope for percutaneous procedures, especially as patients become elderly. And as surgeon himself said, if more than 70 years, generally they prefer to do percutaneous procedure TAVR. And then if it is younger, then when the discussion comes. So what sir has asked me to speak is briefly both on TAVI, that is trans-aortic valve implant, and also briefly to talk about MitraClip, that is a procedure which is done to mitral regurgitation patients. How many of you are sitting here are aware of these two procedures and got involved in sending one of these patients for these procedures? Can you lift up your hands? I think a significant number, and that's a good thing. I think it's appropriate to discuss more about it in this forum too. And then this slide brings best wishes from Apollo Group of Hospitals, where we are trying to network across all the Apollos. And if we are together, that's a strength. PCIs, I think 96,500 PCIs are done only in Apollo Group, and about 1,000 plus structural heart procedures are done. But the only thing is we should be together and learn from West how to publish this data. And then why we are talking so much about TAVI and MitraClip is, as we see, as the population ages, aortic stenosis incidence goes up significantly. And then it happens also with mitral regurgitation, the incidence go up significantly. And then once the incidence go up significantly, not only the treatment wise, then a lot of money gets into in the treating these patients of structural heart interventions. And if we can treat them early with percutaneous procedures and save them lives, it is very good. But the problem is it involves heart team, as it was told in infective endocarditis lecture in the end. You need a multidisciplinary team where you get into cardiologists, cardiac surgeons, and then imaging specialists and critical care specialists, all that. And there's a strong role for imaging, the multimodality imaging, what you call, be it CT angio, be it be interventional echo, nowadays we call it as, all that is very important to decide what type of valve needs to put in this patient. So all of you do not neglect the imaging modalities, be it CT or transesophageal echo to decide. And also, you need some more bigger spaces like this of hybrid OR, a cath lab, what we call, where we do procedures, but nowadays we need it less and less commonly with more expertise in percutaneous procedures. But the idea is, if it requires an emergency surgery, should be able to offer in the same cath lab. And we should be all recollecting this great man, Alan Kribia, who in 2002 did TAVI, the trans aortic valve implant procedure for the sick patient who was about to die. And then the surgeon refused, and he in fact had cardiogenic shock situation. It was done through transeptal puncture through antegrade route. So in 16, immediately the procedure was done in hours time and improved. And he said, what next shall we do? He himself said that he did not expect that it will be advancing so much. And later on, we should be thanking this great man, Martin Billion, who planned the partner group of trials, which made its results applicable worldwide. And we were fortunate through FACS Group to have association with them. We run the combined collaborative meeting with them. That's how my great friend Sushil Kodali came to Apollo in initial days, about 7-8 years back. We started doing towers together. And COVID made us again independent operators. Since then, we have done about 250 plus procedures. And then why we are talking so much is TAVR, this trans-aortic valve replacement has got a revolution, but it just didn't happen randomly. It is actually inevitable result of decades of bold progressive iteration of surgery, cardiac imaging, and transcatheter therapies. As for angioplasty, when somebody proposed that valve can be taken in and just implanted, people laughed, ridiculed, saying that calcium is very tough and surgeons won't be able to remove it, how the percutaneous procedure did it. But this valve did it. What surgeons implant after cutting, it is done through percutaneous procedure with a 14 French now. And why this works so well is, it is just like a stent, what percutaneously we implant in the coronaries is deployed there, take to the right place, and it's balloon expandable, how the stents expand. It's easy to implant relatively, provided you select the correct size of patient size, and behaves like a surgical bioprocess and follow up, though there is some variable data. That's how I think TAVR evolved. In TAVR 2026, no one could have predicted that so much rapid technology evolution happens. There's so many models of valves coming up, and so many trials are being conducted up. But why it became very popular is because of minimalist strategy. What is this? We don't give anesthesia. We don't use TEE now. Mostly it is percutaneous femoral access, minimal sedation, only 1 day ICU stay, or evening shifting from ICU also, and rapid ambulation and discharge plans next day. That's how this has become order of therapy, because it improved outcomes of the patients, and minimalistic approach made us to discharge these patients within 1 to 2 days post-procedure. So then there's so many trials, and particularly about partnered group of trials, which involved more than 9,000 patients. This heart team approach is very important. Again, highlight this. Just because the patient comes to cardiologist, we do TAVR. Just because he goes to surgeon, he's doing a surgical aortic valve is not correct. We need to also have a proper setup where we have imaging experts, heart failure specialists, and then probably dedicated ICU staff like that to do this. And cardiovascular anesthetist role also becomes very important while doing the procedure, where there could be adjustments in pressures, pressure support, things like that. And one thing very important which you all need to see is who is missing in this. The most important is the patient. We need to keep the patient's outcomes. What is good for the patient has to be followed and practiced. That's what, as a heart team, we aim to do it. We came a long way in the TAVR thing, where initial mortality used to be as high as 6.3. Now we've bought into single digit and now to 0.4%. So that is a lot of advancement. We should be all thanking to this partner group of trials led by Martin Leon. Initially, lack of time, we can go into details, but initially it started only for a non-operable patients, then high-risk patients, and intermediate-risk patients. Finally, we came to low-risk patients too, where this all got very highly academically published journals in NEJM. That means they are quite valuable and very well-conducted trials. Why low-risk trial becomes important is because most of the patients of aortic stenosis, 80% of them fall in the low risk. That's why it was very important to prove that TAVR works even in this low-risk patients. What came out in this partner 3 trial is very important. It worked. Surgery has still some advantages in some of the things mentioned. Both of them are equal in pacemaker requirements and some of the times. But what TAVR did better is to have decreased mortality, decreased dreadful complication of strokes, rehospitalization, active kidney injury, bleeding, new onset of atrial fibrillation, ICU stay. Obviously, to be fair to surgical colleagues, all that will be decreased. The length of stay in hospital will be less and the anesthesia problems won't be there. That's how I think TAVR itself is proven. So when somebody to this large audience sitting like this, shows which therapy is better, there's so many advantages, right? Obviously, many of them think that TAVR is better. So that's what proved in Partner 3 trial. Initially, they said it is immediately working, but whether it works the same in the long term, that's what I think 5-year follow-up. Now we have 7-year follow-up showed that even at 5 years, both TAVR and SAVR were working well. That's what is shown, and as late as the 7 years thing is also published. I'll just take you through one case example. Just some of you must be inquisitive to see how the TAVR procedure is done. We first do a femoral artery, because from there we need to take the valve, then put a little bigger sized sheets, and then we also put a temporary pacemaker lead because the valves are deployed at this is a temporary pacemaker catheter which we put. We want the heart to beat faster so that cardiac output is stabilized and the valve can be positioned well. And sometimes if there's very high risk, we put these devices called sentinel device. It's put in the both carotid arteries, but nowadays it's less and less commonly used after some data showed that usage may not be that beneficial. But if a patient is high risk, had a history of TIA, things like that, we still use it. After the sentinel device placement, now we are crossing the valve of aortic valve. Then once you cross it, then this is crossed. Then sometimes we might do a pre-dilatation because if the valve is very narrowed, lot of calcium, it may not allow the valve to go. After the pre-dilatation, then I think you check now, then that is a dilatation. Then you place a more stiffer wire inside. And then this is the valve which is deployed. Nowadays it goes on a 14 French catheter, so it became so thin. It started from 24, now it became 14 French. Now the valve is going across and need to take it carefully across the aortic arch, not to get into stroke risk because sometimes embolism happens. And then once you look for the aortic root, you see the position well and inflate it from outside so that it gets implanted. See that it gets deployed. Then with a rapid pacing, it's beating faster. See the position correctly. And if it is positioned a little low, it might get into LV. Otherwise, it could pop out. That's what is the expertise. And probably now, after that is deployed, then you get the catheters, everything out, and then you remove everything. And then lastly, you should be also, that's no aortic regurgitation, no gradients. It's all checked on table. And then you remove everything. And this patient, the filters are also removed. And you also finally check the femoral artery gets into any trouble because even today, some of the problems happen in the local delivery. Then this valve remains within the body. That's about the balloon expandable valve. On the other front, Evolute front, self-expanding valves are also being studied. And the advantage of it was in patients, females especially, who have a very small annulus, they're supposed to be doing better with the self-expanding valve that comes from Medtronic. We have 4 years and 6 years data show that it works well like surgical implanted valves. The clinical care pathways I have mentioned significantly improved. Clinical outcomes have improved. Now we have reached a mortality of less than 1%, stroke rates in single digits. That's why in 2026, we're not bothered whether patient is high risk, low risk, or for surgery. What we want is which patient does well with TAVR. If there are any particular contraindications like low coronary heights or chunks of calcium, then probably surgery could be still better than TAVR. But that's what we need to look at in this in 2026. Sir has asked me to briefly speak about mitral clip procedure also. The last few minutes I will touch on this. Transcatheter therapies, again, mitral valve, as you know, is slightly different, complex anatomy. So it could be degenerative or secondary mitral regurgitation. And why we are bothered about MR is, suppose patient has a significant MR, 50% of them die within 5 years. That's why it is important for us to treat these patients and appropriately correct that occurrence of mitral regurgitation. Initially, in the low-risk patients, they were all going for surgery. Then high-risk patients were studied for mitral clip. And the same thing was happening even for the functional mitral regurgitation. Then now, the patients falling into very high risk, they were left on medical treatment now, then probably we are aiming to get this mitral procedure even there. Some of you must be aware of this MITRA-FR trial which came negative and then COOPT trial which came positive. And that is because a subgroup of patients which are involved, it needs minds of Greg Stone to prove the trial positive. If you take a patient who has a significant MR and not much of LV dysfunction, that's where they benefit. If otherwise patients is having severe LV dysfunction, not much of MR, they won't benefit. So this produced dramatic benefits, reduction in mortality with this mitral clip. All-cause mortality is decreased, and MR reduction obviously happens. Then that's how now 5-year follow-up is also checked even for mitral regurgitation, showing that hospitalization decreases, mortality is decreased. And then, but one thing we need to note, even after the long term, after the clip procedures, also significant patients could die because they all have a lot of morbidities too. That's why this 5-year study showed that still we need to work on further apart from just being happy only with mitral clip. So what is the sweet spot for this optimal patient for this mitral clip procedure is MR should be severe, LV function should be at least slightly better, not very severe dysfunction, and optimal guideline directed medical therapy should be given to these patients at least a month before they take up for procedures. So operators should be experienced and there should be good candidates for mitral clip. Then this mitral clip procedure will do well. And then probably now from extremely high risk, it's moved to low risk also. That's how this mitral clip procedure is also picking up with operator expertise, and definitely it produces a lot of symptom benefits. I'll show you one example where this patient was rejected by surgery, severe mitral regurgitation. From starting to end, we could finish the procedure in 2 minutes of time. That is a great importance of a 3-dimensional echo. It's mostly echo-dependent procedure where while deploying the clip and all, we check regurgitation happening on this is one of the patients whom stepwise deployment recorded. Then that's how the initial mitral regurgitation jet, which is very severe, after the procedure is done, it significantly decreases. There's so much of research going on addressing to various other mechanisms in the MR. Then, but what is more nowadays being studied is the mitral clip is moving to low risk procedures, and then probably newer clips are also coming live with Pascal, which have some advantages. But people are also vexed up with the variable results of the clips. So now the TMVR is likely to come up where whatever mechanism of mitral regurgitation happening, then whether it be leaflets, chordae, everything, it could be treated with valve replacement procedure. That's what is the thought process going. But now it is of 30 French and it's done through venous route, transeptal puncture. Gradually it's going to valve replacement here too. And a lot of new mitral valve procedures are also coming up. Mitral valve percutaneous replacements are also coming up. And we are in the process of conducting this Apollo TMVR trial, where what will be done in future, probably we do more and more complex cases and patients who, before they develop overt heart failure itself, we could treat these patients of both for TAVR and mitral clip. There are lesser French valves coming up, like CGL valve, which goes through 8 French, and early TAVR Avatar trials are also being studied, and aortic regurgitation is also being tested with this new Cardiology valve, apart from aortic stenosis. Align AR trial showed 2 years trial, and then this ARTIST trial is showing that in aortic regurgitation too, we could do TAVR. So accessory devices are also coming up where before aortic stenosis becomes severe itself, you could treat those patients. We do all this with a single point agenda that we want our patients to do well. This patient is referred to us from Nagpur, 80 plus female. After doing TAVR, went to Wotan. She was not able to lie down in bed after doing procedure. Then probably patient got good outcomes. That's why we want to do such, and more such discussions will happen in our upcoming meeting, where Brajesh sir and others will be part of it. Request all of you to book your dates and be part there to have more discussion on these percutaneous valve therapies. Thank you again for the patient here.
Thank you very much, Dr. A. Srinivas Kumar, for an elaborate talk on TAVR and mitral clip. In the discussion, we are going to have a discussion on TAVR and SAVR and repair part.
Thank you.
May I invite Professor Peter Kala, who is the head of the Department of Internal Medicine and Cardiology, University Hospital, Brno, Czech Republic. Over to Dr. Peter Kala.
Hello. It's my great pleasure to be here, to be with you. And I would like to thank Dr. Mittal for his kind invitation to your meeting. That is the 10th meeting of Shakeheart. And I think that I've been participating most of the time. So I will talk about some different topic today than TAVR and other instruments. But I will talk about the breaking the clot. And it's quite amazing topic because it will be about catheter-based solution for acute pulmonary embolism. And I would like to give you my best regards from Brno, from my city, from the Czech Republic. If you are talking about deep vein, vein thromboembolism, so the incidence is 100 up to 200 per 100,000 population per year. Deep vein thrombosis definitely has a negative impact on morbidity and quality of life. And literally, it's the third most often reason for cardiovascular mortality, the pulmonary embolism. In my country, and I think that it will be very similar in other countries. So in my country, there is, before the pulmonary embolism, there is the reason of heart failure and arrhythmias as well. So not only acute myocardial infarction or coronary artery disease and stroke, but also heart failure and arrhythmias play an important role. We have the increasing incidence of deep venous thrombosis and pulmonary embolism, but decreasing mortality. So in total, it's a similar number of deceased patients during time. If you talk about the risk classification of pulmonary embolism, it's quite important because it indicates the potential therapy and maybe also the improving of our possibilities of treating the patients. And you can see that we can divide. Definitely, we have very good classification for high risk pulmonary embolism with hemodynamic instability, clinical parameters of pulmonary embolism severity or comorbidities, right ventricular dysfunction. It can be on transthoracic echo or CT pulmonary embolism, a pulmonary artery angiography, and so elevated cardiac troponin levels. Maybe it could be also some lactate and other biomarkers that can be used. And after that, we have intermediate risk. And what is, for me, it's quite important, the intermediate high risk population. Because in the intermediate low risk or low risk, so definitely that's not so much important how we treat this population. Because we can go with pharmacology, and if it fails, so we could think about something different. The therapy of thromboembolism, in most cases, around 95% of cases, we use anticoagulation. And we have quite good, but relatively old guidelines from the European Society of Cardiology. If you are talking about the thrombolysis, so we have indication for high risk pulmonary embolism. It should be used as a systemic, but we have to have in our mind that the evidence is extremely low. Just less than 10 patients, but it's very fast and in quite a lot of patients, quite effective. If you are talking about the proximal deep vein thrombosis, so in selected patients, we can use local thrombolysis or other intervention. What are the alternatives of treatment of pulmonary embolism? And regarding patients, there are patients with relative or absolute contraindication to thrombolysis. There are patients after failed thrombolysis. There are patients elderly or very frail as well. And we should think about other possibilities of treatment with intermediate high risk pulmonary embolism at high clinical risk. Of course, the shock patients are the most dangerous situation. We have very good SCAI shock classifications. And if you are talking about the A, B, C up to E classification score, so of course, what we should be able to avoid D, E classes of the sky shock situations. So what when we offer now? Besides the systemic thrombolysis, we have catheter-based therapy of pulmonary embolism with or without thrombolysis. And we can also use the veno arterial ECMO plus minus catheter-based therapy. And of course, we have the continuous unfractionated heparin that is, in fact, more important than a low molecular weight heparin in patients. And of course, we could think also about cardiac surgery and about embolectomy. But this is a quite difficult procedure. And of course, if we don't have enough time, so this is difficult to provide the patients. So what can we see here? The large bore possibilities and also the local thrombolysis. In fact, we have had quite extensive experience with local thrombolysis of pulmonary embolism, especially intermediate high-risk population. And what you can see here, these are the markers of the catheters. And through the catheters, there is local thrombolytic infusion. The regimes of local thrombolysis are different. It can be from 10 milligrams of alteplase up to 20 milligrams of alteplase, different duration, and some different bolus at the beginning of the procedure. And also, we have thrombectomy catheters, so large bore thrombectomy extraction. This is quite effective. It's very fast. Of course, it needs quite a lot of experience and a very experienced team as well. So for the intermediate risk pulmonary embolism, there is one randomized trial that was published. That's a peerless randomized trial. And it randomized 550 patients, but there was no cohort of patients that would be treated conservatively with some anticoagulation. All patients were treated with catheter-based therapy. And it was catheter-derived thrombolytic therapy or large bore thrombectomy. And what were the results? And the results were in favor of large bore mechanical thrombectomy. At the same time, you can see that the procedure time was longer. And besides that, there was higher blood loss and practically the same time from admission to therapy. Different systems, different catheters. So maybe that could be a limitation of this trial. And it was in favor of large bore thrombectomy. But the difference was derived not by the heart endpoints, by hospitalization. And you can see that it was about clinical deterioration and or escalation to bailout therapy. And post-procedural ICU admission and ICU stay more than 24 hours. So to have better data, of course, we need some more evidence to be able to indicate more patients for this therapy. Now we have finished the enrollment of patients into Prague 26 randomized controlled trial, and it was intermediate high-risk pulmonary embolism, more than 550 patients in multiple Czech centers. So quite extensive experience in my center. And the therapy, the local thrombolysis, was delivered within 3 hours from randomization. And the first results should be expected at the ESC Congress this year. What about the guidelines? If you are talking about the high-risk pulmonary embolism, these are the guidelines. you can see that the evidence, what is the evidence? So mostly class C. So expert consensus. So that's definitely not the best evidence we would like to have. And we have systemic thrombolytic therapy is recommended for high-risk pulmonary embolism, class 1B. And of course, if we deliver the systemic thrombolytic therapy, of course, there is a risk of bleeding. And what we would like to avoid is the intracerebral hematoma. Besides that, we have an indication for surgical pulmonary embolectomy. And you can see that 2A, we have percutaneous catheter-directed treatment. And ECMO may be considered, but the evidence is, again, class C, consensus of experts, and 2B only. I would like to share with you one case. That was for us quite important case, and with high risk pulmonary embolism, quite young female, 36-year-old, without any comorbidities, no medication, but the patient had a car accident with liver laceration and multiple bone fractures. So the surgical therapy was delivered with liver tamponade and spine stabilization. Patient was extubated on day 2. On day 3, there was a planned second look. And after the liver tamponade extraction, so there was pulseless activity, CPR, and fortunately, very short ROSC, only 2 minutes. And on echocardiography, there was a massive pulmonary embolism and acute right ventricle failure visible. So you can see the CT angiography here. And on the right side, you can see the settle thrombus. That's maybe typical. And so quite a lot of thrombus formation was inside the pulmonary arteries in both right and left pulmonary artery. This was the echocardiography. You can see that this is really a very dangerous situation. The patient was in shock and on catecholamines. And what we should do next? Of course, we could discuss. And what should be the next step? What would be the next possibility? Of course, the patient was contraindicated to any thrombolytic therapy. So our approach, based on our experience, was first to deliver veno-arterial ECMO to stabilize the patient. And after that, of course, the large bore thrombectomy of pulmonary tree at the same stage. So during the same procedure. But this is for me quite important. So you have to have experienced ECMO team, and you have to have experience team for thrombectomy of pulmonary artery. So this was the picture, just a picture after the thrombectomy, and you can see that there was a relatively good flow into the both right and left pulmonary arteries after thrombectomy. This was extracted. So it was a really huge thrombus formation, especially in the left pulmonary artery tree. And we used ECMO for arterial 17 French, for venous 21 French. The thrombus was extracted from the left pulmonary artery by using 24 French, so really large bore triver. And we used 4 aspirations on the left and 1 on the right, but there was no thrombus extraction. The fluoroscopy time was 16 minutes, contrast only less than 30 cc, and the total procedural time was 95 minutes, including veno-arterial ECMO therapy. The blood loss was quite low, 40 cc only, and mean blood pressure after thrombectomy was only 16, so normal, quite normalized. And this was echocardiography just after the thrombectomy, so still the right ventricle failure, but better than before. And this was 1 month after. The patient was, of course, extubated, discharged home, and the lady was going after that in very good condition. So practically normal echocardiography finding at 1 month. So if we are talking about high-risk pulmonary embolism therapy, so catheter-based therapy with or without thrombolytic therapy. So patients definitely should be indicated if they have contraindication to thrombolysis. And there are many possibilities, many clinical situations that can be found. Patients at high clinical risk, we can talk about very elderly patients or elderly patients, patients with cancer, thrombocytopenia, coagulopathies, frailty, etc. And of course, there are patients with failed systemic thrombolysis. Our experience has been quite extensive in this matter. And so we developed a PERT, that means Pulmonary Embolism Response Team of our hospital. And it includes cardiologists, intensivist, interventional cardiologists. And we have a WhatsApp team, and there is a quite fast team decision about indication of catheter-based therapy and its type as well. Because I have to say that the local thrombolytic therapy is quite effective as well, and with quite low amount of altiplays. So we developed a 24/7 program from 1st June of 2024. And at that time, we had already well-established ECMELA program. That means ECMO and Impella treatment. So we combine these teams. So it's ECMELA and PERT as well. Regarding the real-life situation...
I think we're just short of time. You can please conclude, organized.
Okay. This is from US, and there is this is registry and real data. And coming to the summary, so it's extremely important to have PERT. It's extremely important to have complex patient evaluation, to have possibility of veno-arterial ECMO. Intermediate high-risk patients, we can use several possibilities of treatment. In high-risk pulmonary embolism, we should think about mechanical thrombectomy, and there is experience that plays quite important role. The 24/7 availability is a question. There is a lot of trials going on, and one of them, Prague 26, should be presented this year, and high peso as well. So thank you very much for your attention and for the invitation again.
This is Dr. Mittal. Can you hear me?
Yes, I can hear you very well.
Yes, good morning. So Professor Kala, if I would like to introduce to the audience that he is a Stand for Save Life mission. He was the chairman long back, and he was the one who was pioneer in establishing the role of primary angioplasty. So now Professor Kala has moved from coronary thrombosis to pulmonary thrombosis, it seems, and a very, very distinguished professor as well, a regular faculty in our conference successively for 10 years. I don't think we missed you ever. You always find time for us. So thank you for being with us. We have only 5 minutes maximum before we conclude this session. And I would request Dr. Kala, if you can be available between 1 and 1:30 Dubai time. That's just a formal inauguration ceremony.
Excellent.
If it is possible. Thank you.
I'll be there.
Thank you.
Thank you very much.
Samir, you would like
Any quick questions? Anything?
Thank you very much to all the speakers for excellent presentations of their topics. I had one question for Dr. Bhatnagar. When you are doing for native valve endocarditis as an elective case who has had, let us say, 4 weeks of antibiotic therapy, is there any role in repeating the blood cultures prior to surgery, or we just go ahead? Because after receiving appropriate antibiotic therapy, you don't expect the blood cultures to be positive, but the patient still has regurgitation or vegetation sitting on the valve.
I mean, if there's any evidence of ongoing inflammatory disease, infection, certainly we'd want to do that. I want to make sure their white counts are normal, their CRP, their procalcitonin is all normalized, and there's no increased vegetation. So if there's no signs of active infection, I wouldn't necessarily just do random blood cultures on those patients. I'm more than happy for them to come back if there's no abnormal inflammatory markers, and then we'll take care of their aortic valve. Well, almost all isolated aortic valves now also can just be done through a minimally invasive incision. It's a surgeon's choice whether we do a small upper J incision or very often, just a small thoracotomy incision for isolated aortic valves.
Thank you.
Of course.
One or two maximum.
Can I ask one question to Dr. Calder?
Yes, please.
Can you hear us, sir? I'm Dr. Srinivas Kumar from the hall here. Which is your preferred modality of suction method for pulmonary thrombus? Any particular device you prefer over the others, or all are same, you feel?
So thank you. We have two devices now, commercial available, and we have more experience with the FlowTriever, 24 French or 20 French, but especially 24 French. But at the same time, we have the Penumbra. New type of new sort of the device, and so for me it's if you have experienced team and especially two operators, so FlowTriever would be my best option. If there is one operator, so Penumbra is definitely better for the manipulation.
Thank you.
Just a question.
Last question,
for
yeah,
Dr. Srinivas Kumar. Any role of steroids or colchicine and TAVI for leaflet thrombosis, conduction disturbances, or need for PPI?
No, for steroids, there is no role. But post-procedure, some people are finding it very early thrombosis. That's where I think people are trying dual antiplatelet therapy and small dose NOAC therapy. But colchicine and steroids are not tried in this particular thing.
Recently, in Euro intervention, they presented a trial glucotavi, in which they used methylprednisolone followed by 5 days of prednisolone. And they found there is a numerical decrease in the need of PPI as well as leaflet thrombosis. But it was not statistically significant, and they suggested the larger trials are required, and same holds true for colchicine also.
But generally, sir, in steroids...
Generally, it's not, yeah. It will take larger trials to come into the practice.
My one question from Dr. Srinivas Kumar. How many burden you are having of aortic valve disease in your non-invasive lab, 2D echo, and how much burden you can share through TAVI? And how many percentage of patients you are referring for the cardiac surgery?
I think that's a good question. What Sir is asking is overall incidence of coronary aortic stenosis in your cath lab. Compared to the overall number of patients, predominantly still there coronary artery disease, LV function assessment. Out of the valve diseases, probably because of aging patients, the dominant presentation is the aortic stenosis. Out of which now, whenever we have a protocol in the lab that whenever gradients are flow velocity across aortic valve crosses 4 meters per second, the tech there informs the echo specialist first and they assess and they send it to us. I think still in India compared to West, where in US statistics wise out of aortic stenosis with elderly, 50% of them or 60% of them go for TAVR. In India, only 10% of the population goes for TAVR and 90% are still sent for surgery. Because age is also probably less in our subgroup of country. The patients are 70 years plus, undoubtedly they prefer TAVR, both patients and surgeons. But the controversies only are in between 65 to 70 years of age. And if it's less than 60, definitely only SAVR should be done, not TAVR. The gray areas are somewhere in between 60 and 65 years of age group.
Okay, thank you. I think, Dr. Ajit, we have to stop over now. So this concludes session number 2 of the morning. Please, we'd like to felicitate Dr. Bhatnagar and rest of the faculty for this. So please come over. There is one announcement that after this, there will be a short coffee break, which was assigned for 30 minutes, but now we'll reduce it to 20 minutes. And second thing is, henceforth, as from now, this whole proceeding is also available online, and you might have received email if you want to click on your mobile and see outside here, wherever that's possible. And third thing is, right from the beginning, 2021 onwards, on the website and the YouTube. Every single session, every single lecture is available, and this will also be made available very soon, within 1 week. So you can hear any last lectures, any this current lectures, whatever. Everything will be available. Okay. So please, Doctor. No. Yeah. And we have a special applause for Dr. Peter Kala for sure. And thank you for always being with us and encouraging us. And I'm still waiting and hoping that someday, once again, you'll be in person here. Thank you.
Thank you. Good luck with the meeting.
Dr. Srinivas. Tell the time. We'll give at the time of lecture. Yeah. Okay. Fine. Yeah. Thank you. So we now break for the coffee. 20 minutes. Please be back with us. Thank you. I take this privilege to invite the chairpersons of the next two sessions, session number 3 and 4. Dr. Praful. Dr. Praful is a consultant intervention cardiologist in the Dubai Hospital. Then Dr. Selvin George. Dr. Selvin George is my esteemed colleague, internist, head of internal medicine in our hospital, Medcare, and none other than Dr. Fatima. Very, very old colleague. So we know each other. We worked together in 2009, 10, and onwards. Thank you, Dr. Fatima. Please join us. And I leave upon this podium to you. The next two lectures and next two sessions, in a way, are both to be shared by your team. So I believe the speaker is available now. You can please announce the speaker.
Good morning, everyone. We have earlier in the morning listened about invasive management for different cardiac issues, but medical management is equally important. So we have got some important discussions on the medical management of cardiovascular diseases. So first up is Dr. Srinath from Shakeheart Medical City. He will discuss about the role of ranolazine in chronic ischemic heart diseases.
Good morning, everybody. At the outset, let me thank Dr. Mittal and the organizers for inviting me, and a special thanks to Minarini for asking me to give this lecture. As rightly said by the chairman, I used to be an invasive interventional cardiologist, and over a period of time, I became a non-invasive cardiologist. So I have the experience in both fields. Without wasting much time, do I change the slide from here? Yeah, this one. This forward and this is backward. Okay. Let me just start with a simple case. A 60-year-old man with all multiple comorbidities has a ACS in 2020, has an angiogram, does a PCI to LAD, 50% stenosis and RCA. He was an optimal guideline treatment. Then again, he comes back in 2023 with another ACS angiogram done, LAD stent is patent, the RCA lesion has progressed, he has a PCI to RCA. Then he again is put on more intensive medical management. Then in 2025, he comes back with chest pain on effort. So as all we do, we just do a stress test. Stress test is equivocal in the sense that he walks for a few minutes, complains of chest pain. There is non-specific change in the ECG, so he goes for an angiogram. The angiogram shows the patent stents in RCA and LAD, and there's no other significant lesion in the coronaries. And he's an optimal medical treatment because he's on a good dose of statin, he's on a antihypertensive medications, good dose of beta blockers and nitrates. But the patient keeps on coming to your clinic getting chest pain. So what do you do next? This is the common dilemma all of us face. As rightly pointed out by the speakers in the first session, doing a PCI itself does not solve the issues. Almost 20 to 30% of the patients who had revascularization come back with anginal symptoms in the next 1 year. This is shown not by a single study, but multiple studies all over the world. And as Dr. Gupta has shown you in the morning, coronary heart disease is complex. It is not just epicardial disease. There's a lot of things going on at the microcirculation. There's inflammation, there is microcirculation, spasm, resistance, and so on and so forth, what we call as microvascular disease. And unfortunately, we don't pay much attention to this microvascular disease. There's something happening with the endothelium, with the nitrous oxide and the prostaglandin and so on and so forth. So when we take patients with angina and then do an angiogram, almost 50% of them will not have any significant lesion. This is what we call is angina with normal epicardial coronary vessels. And this is what we call as the microvascular disease, coronary microvascular disease. And to establish a diagnosis, we need a test in the cath lab where you actually measure the microvascular flow and the microvascular resistance, for which you need special catheters, which are probably not available in all the cath labs in this place. Is angina common? I said the angina is common. This is the study from about 25 US cardiology practices. Almost about 20 to 25% of patients have an anginal episode almost every week. But this is actually ignored by most of the physicians. And not only is angina common, but it is also undertreated. If you look at the treatment which the patients receive for angina, almost more than 40% of the patients are actually on no anti-anginal medications or on a single anti-anginal medications, because we think the patient's symptoms are not genuine because we don't recognize this microvascular dysfunction exists in most of our patients. So treating microvascular dysfunction, does it help the patients? The answer is yes. Patients who take treatment for anti-anginal treatment with microvascular dysfunction actually do much better, almost 30% much better compared to patients who are on a placebo treatment. Does treatment for microvascular disease help the patients in the long run? The answer is yes. See, if patients who have got a good microvascular reserve, that is where the microvascular reserve is more than 2 or 2.5 times the normal, actually do much better compared to patients who have got low microvascular reserve. So the events are much higher in patients who have got low microvascular reserve compared to patients who have a normal microvascular reserve. So coming to the drug, I'm sure all of you must have heard this drug ranolazine, which has now picked up as because the guidelines have started recommending ranolazine as one of the important agents to treat angina. So what is ranolazine? Ranolazine is a drug which actually blocks the slow sodium channels. So we know the sodium and potassium channels are responsible for the generation of the electricity in the heart and propagation of electricity. So the rapid sodium channels are responsible for the initiation of the QRS complex, whereas it is sustained by the source sodium channels. So what does ranolazine do? Ranolazine blocks the phase 2 of the action potential. So we all know that the sodium channel blockers, potassium channel blockers are mostly antiarrhythmic agents. So how does ranolazine, which is being marketed as an anti-angina agent, to do with the sodium channels? Actually, we know the class 1 antiarrhythmic agents are classified as class 1 A, B, and C. So actually, ranolazine comes as a class D because it acts on these late sodium channels. And when it acts on the late sodium channels, it also delays the repolarization, leading to a prolongation of the QRS, the action potential duration, and the effective refractory period. In a sense, ranolazine is an antiarrhythmic agent and has been used off-label as an antiarrhythmic agent, but the guidelines have not recommended ranolazine as an antiarrhythmic agent, but it has been recommended as an anti-anginal agent. So how does ranolazine, which acts on sodium channels, works as an anti-anginal agent? We know whenever the sodium channels are open, that's what happens in a patient that's got ischemia or heart failure. Most of the sodium channels are open, with the result there is a lot of sodium influx into myocardial fibrils, and then there's a sodium calcium exchange mechanism. So more sodium inside the myocardium causes more calcium, and this leads to increased ATP demand, increased oxygen demand, and that leads to ischemia. Not only that, it also leads to increased myocardial dysfunction, the diastolic dysfunction, and arrhythmias. So more sodium causes more calcium to enter, and that's how it causes a worsening of the anginal symptoms. So what does ranolazine do? Ranolazine actually blocks the phase to the source sodium channels and not the rapid sodium channels, with the result that there's an decreased calcium flux into the myocardium, causing a blockage of this vicious mechanism of increased calcium overload and then reduction of ischemia. So what do the guidelines recommend? So the latest European Society guidelines actually recommend ranolazine as the first line management of patients who have angina not responding to first line of drugs. The level of evidence is A, and the recommendation is class 2A. So if you see earlier recommendations in the previous guidelines, they had included nicorandil, ivabradine, and trimetrazine. And now the latest guidelines have downgraded the other agents. And then the first agent recommended as the anti-anginal agent after beta blockers or calcium channels blockers is ranolazine. And then there's an interesting statement from the European Society of Cardiology saying that patients with angina need not always go for an invasive strategy. You should have, now we have got drugs which actually control symptoms much better than just doing a PCI, because we know almost 20 to 30% of patients, even after PCI, come back with anginal symptoms. So always it is a best practice to optimize the medical management before subjecting the patients to an invasive procedure. Similar recommendations have come from the American Heart Association. Again, the recommendations class 1. They recommend that in patients with coronary heart disease and angina, ranolazine should be the first line drug to be used if they are not able to tolerate nitrates or nitrates are not effective. Because we know nitrates are not tolerated by many patients because it causes headache, dizziness, and lightheadedness, and there's a significant nitrate intolerance in these patients. Similarly, the American Heart Association also recommends ranolazine as one of the drugs for management of patients with microvascular angina. Of course, the baseline therapy for microvascular angina is again statins, aspirin, and ACE inhibitors. And again, the beta blockers are calcium channel blockers. So if after the baseline therapy, the patient continues to be symptomatic with microvascular angina, ranolazine should be the drug of choice in these patients. What about patients with diabetes? I know all of us who have been practicing cardiology for a long time, we know patients with diabetes have severe disease, which are actually very difficult to manage because they're not amenable for revascularization as a surgical or by PCI. And then the patients keep on coming with angina. And sometimes you don't have a significant epicardial disease, but the patients have significant angina. So again, these guidelines specifically recommend that in patients such as diabetes, coronary heart disease, and refractory angina, a drug which acts as a microcellular level, like ranolazine, should be recommended. And then the advantage of the ranolazine is that in all these studies with ranolazine, there is a good control of the hemoglobin A1C, almost 0.5 to 0.7% reduction of the hemoglobin A1C. So it not only works as an anti-anginal agent, but also works as an anti-diabetic agent, because any drug for diabetes, I'm sure, reduces the hemoglobin A1C by 0.5 to 0.1%. So why do the guidelines recommend ranolazine as the first choice? And then they were randomized into two groups, one receiving ranolazine 1000 milligrams twice daily, and the other group on a placebo. Although the primary endpoint of MACE did not showed a trend towards better outcomes with ranolazine, but it did not achieve the statistical significance, but the anti-anginal effects were remarkable. The patients had less angina, less frequent use of the sublingual nitroglycerins, and then their effort tolerance improved in the study. So when the patients in this study underwent a stress test maybe after 8 to 12 months, the patients had a longer duration of exercise, had a lesser ST segment depression, and then they took a longer time to develop angina compared to patients who were on a placebo, indicating that ranolazine actually improved the exercise tolerance and improved the angina threshold in these patients. So, and then this level was achieved without reduction of the heart rate or blood pressure, unlike the other drugs which cause hemodynamic changes. Ranolazine achieved the anti-anginal effect without a significant reduction of the heart rate or blood pressure. And then there was no significant side effects in the large group of patients who were studied. So the summary of the study was that ranolazine improved, reduced the anginal frequency, reduced the need for sublingual nitroglycerin, and increased the effort tolerance of this patient. Another study which was done specifically on diabetic patients with coronary artery disease and angina is called the Teresa study. Almost 1,000 patients were there in the study. So what it showed that if patients who used the ranolazine in this group of patients had lesser angina and lesser use of sublingual nitroglycerin, again indicating the same thing what was found in the TIMI 36 study. And this is the study which made the guidelines recommend the ranolazine, especially in diabetic patients, because in patients who used ranolazine, the hemoglobin A1C was reduced by 0.5 to 0.7%, indicating a good diabetic control. I know better diabetes control means lesser inflammation and less vascular disease. So the American Heart Association and the European Society actually specifically named these two trials, TIMI 36 trial as well as the Carissa trial, as the landmark trials for use of ranolazine in patients with diabetes mellitus. Is there the real world data? Again, this is a data from the year 2024, which took patients who are coming with angina with multiple risk factors like diabetes, hypertension, smoking, and so on. What about microvascular angina? Microvascular angina is sometimes difficult to treat because, I said the patients are on aspirin, statins, and ACE inhibitors or ARBs. They are also on beta blockers or calcium channel blockers. But we always need to combine. So when you use combination of drugs, then we have some limitation with blood pressure and sometimes with the heart rates, so on and so forth. So ranolazine was one drug which can be safely combined. This is a study. Of course, a small number of patients, about 60 patients. Patients who were given ranolazine actually had a better improvement of coronary flow reserve compared to patients who did not use. And I said as earlier, if the coronary flow reserve improves, your MACE comes down, and then you have a lesser frequency of angina and lower use of sublingual nitrates.
Thank you. So for the next talk, it's my pleasure to welcome our chairman of Shakeheart, Dr. Brajesh Mittal, who of course needs no introduction. He's also the medical director of Medcare Hospital. He's also the head of Department of Cardiology in Medcare Hospital. Now he's going to give us a talk about achieving very low LDL levels. Listening to his many talks over the years, he's one person who believes in lower LDL, the better. And we also have followed his footpath, and we also advise our patients about achieving very low LDL. He's going to talk about the role of evolocumab in achieving ultra low LDL targets. And let's listen to him right now. Thank you.
Thank you, Dr. Salvin, for the generous introduction. This is my pleasure to be here and as a speaker now. So the talk currently is, this particular talk is on ultra low LDL cholesterol achievement. So we all know without doubt that cardiovascular disease is a leading cause of death in the world. And as a data, it kills more patients than cancer, respiratory disease, and diabetes combined together. And in fact, the double the rate with cancers alone. It is out of the several factors, LDL cholesterol is one of the top modifiable risk factors for cardiovascular disease, besides systolic blood pressure and diet and air pollution, smoking, and obesity. It is not exactly the actual number of LDL, but it is also the exposure to the LDL, which is a key predictor of ASCVD risk. Now, increasingly, we know that somebody at the age of 30, if he has the LDL of 130 versus somebody who has at the age of 60 has LDL of 160, it's a total log, total exposure of a lower cholesterol level to a longer level versus high cholesterol level for a shorter level. That makes a difference too. So elevated lipid counts, these account for the largest proportion of the risk for cardiovascular events, more than the diabetes, smoking, whatever you see. But in the end, in the orange, you will see the role of lipids, which have the highest attributable risk for cardiovascular disease, more than anything else, which are also important. And this is a reliable surrogate marker. Reduction of LDL is a very reliable surrogate marker for improving cardiovascular outcomes. If you reduce 39 milligram per DL of LDL or 1 millimole per liter, you are reducing actually 22% of the risk reduction. And this is not based on one trial, but on multiple trials in a large number of patients. So clearly it was shown in several trials that lower the LDL achieved, the lower the risk of cardiovascular events. The TNT trial, very famous trial between 10 and 80 milligram of LDL. Jupiter trial, when patients were on less than 50 LDL or more than 50 LDL. And Prove-It trial with pravastatin, a lower, weaker statin was compared with the atorvastatin. All these trials show that if you have the lower the LDL, you as much as you low, as better you get and you achieve better targets in terms of reduction of the cardiovascular outcomes. So lowest is best, and the initial evidence was primarily based on statins, which we all know is the crux of the therapy, both in the primary prevention setting as well as in the secondary prevention setting. But increasingly, we got to know that lowest is best. There's no lower number which you can say can be harmful or should not and should be avoided. It is nothing like that. And now we have also a clear evidence with non-statins. So additional lowering of LDL cholesterol with non-statin medications on top of statins resulted in incremental reductions in cardiovascular disease. So our armamentarium is increasing. The greater the LDL cholesterol reduction, the better the clinical outcomes, irrespective of whether you are using only statins or statin with additional medication. The patients who have a cardiovascular event are at increased risk of another cardiovascular events. In the morning, Dr. Lochan showed multiple cases. So all these patients are surviving, not just because they were treated at that time, but subsequently they were treated so well and they require such a good treatment so that they don't suffer again, because the repeat suffering is very, very high. It was shown in the beginning that after an MI or a stroke, risk of another cardiovascular event is 1 in 3, which is extremely high. And our duty is to prevent that. And one of the crucial factors to prevent that is to reduce LDL to as low as possible. And that is why we call it ultra low reduction. Only 1 in 5 MI patients achieve LDL targets despite all this knowledge and information. So we are lagging very far behind. This was based upon EuroAspire 4 trial. Only 20% patients reached the target of LDL less than 70, which was the target in that trial. But actual targets are even much lesser now. Now we are going to 55 and 40. So 50% of patients discontinue their statin within 2 years. That is another problem. Even if you treat the patients with the statins, they don't continue, they don't persist, and they have the perceived side effects, which is one of the leading causes of discontinuation. So a large proportion of patients, even in our region, in the Gulf and Middle East, do not achieve their lipid targets. It was shown in Cepheus trial and Diasis trial, 48% and 68% respectively. So LDL cholesterol lowering is an integral part of ASCVD primary and secondary prevention. However, many patients are unable to consistently achieve and maintain LDL cholesterol goals with current therapies. We often have such kinds of patients. This gentleman Uh, 5 years back, we treated him, 66 years old, primary PCI, RCA, very high thrombotic burden. And apparently he treated well, he recovered well, his ST segments became better. But then what we got to know, we have to understand that successful angioplasty is only the beginning of treating this patient. This is not the end of the treatment. This is actually the beginning. When we saw this patient's reports, because this was a naive patient, he had very high LDL, more than 250 in the primary hyperlipidemia range. He had also hypertension, untreated. He had moderate mitral regurg. He had type 2 diabetes. Nothing was known, nothing was treated until that time. And we started him on lipid lowering therapy. He was not able to tolerate atorvastatin plus ezetimibe, though still we persisted, and still LDL remained 105. So this was a very high risk patient. And finally, we had to go to evolocumab, PCSK9 inhibitor, and then he achieved target of LDL 48. In fact, he achieved 30, but he insisted on reducing his statin. So when we reduced the statin to 40, he maintained on 48, which is still much better. So for lipid lowering, we have to act early and we have to treat aggressively. Both the principles apply. Higher risk patients have more vulnerable plaque. Early and aggressive LDL lowering stabilizes plaque and improves outcomes early and late both. Starting earlier translates to a lasting legacy of benefits. The longer you treat the patient, the longer duration you keep the patient's LDL low, the better you have the long-term outcomes. So clinical translation most effective at the time of an event because that is a vulnerable part at that time. So for that, in this context, the non-statin therapy which is emerged in last 1 decade is a PCSK9 inhibitor as one of the few therapies. I won't say we have a lot of non-statin therapies, and we need to know a bit more about PCSK9 inhibitor. So we know that cholesterol homeostasis and maintenance is done at the level of not just cholesterol synthesis. It is actually at the level of LDL receptors. So if you have more receptors, you have more clearing of LDL. So what we need to do is we have to preserve the LDL receptors. So what does PCSK9 does? PCSK9 is a substance which reduces the LDL receptors, and PCSK9 inhibitor actually increases LDL receptors. So we increase indirectly the LDL receptors so that there is more LDL clearance and reduction of the LDL levels. So this is what this PCSK9 inhibitors came, and one of them was evolocumab, with which we are talking today about. And this was an Osler trial, the first trial, 2014 it came, and that was an open label trial, and it showed a huge reduction, 61% reduction in LDL cholesterol as compared to the control group, and an absolute reduction of 73 milligram per DL. I do not think any trial ever before showed such significant difference in the LDL or reduction in the LDL cholesterol. And it also translated into cardiovascular outcomes. And then came the 4-year trials. And both these trials were conducted by, you can see the second author, Dr. Gigliano. And we are very proud to have him as our own speaker in this late evening as a last speaker. And he will be speaking about Vesalius, another new trial which he conducted on evolocumab. So he's the main person behind evolocumab trials, and he'll be our speaker. So please don't miss his talk this evening. So this was the trial design. There were very large number of patients in 4-year trial, 27,000 plus. And they were very high risk patients, and they were divided into 2 groups. And again, we saw a 59% mean reduction and absolute reduction of 56 milligram per DL in the LDL cholesterol levels. Primary endpoints were significantly achieved, and secondary endpoints were also achieved significantly. And this trial concluded that evolocumab reduces LDL cholesterol by 59% and reduced cardiovascular outcomes in patients already on statin therapy, and it was very well tolerated. Then this trial was conducted as open label extension study, and this is known as 4-year OLE study. And in this study, the patients who were on 4-year trial as a control patients were also given, the placebo patients were also given evolocumab, and then subsequently they also achieved the same kind of LDL cholesterol reduction. So this was a very, very important trial which gave us a lot of information after the Osler trial. And based upon these trials, if we examine the guidelines in 2025, focused update of ESC guidelines, when we have clearly been shown to go to ultra low levels, less than 40 milligram in the very high risk group patients. For the first time, we were told, or we were informed, that you have to bring down to less than 40 in extremely high risk patient. and then the role of these medications come. So we are fortunate to have in our armamentarium, besides the statins, non-statin medications like ezetimibe, like bempedoic acid, but then much more powerful and effective are the PCSK9 inhibitors. And if you see that at the end of the graph, if you combine all the available therapies, you can reduce LDL cholesterol by 86%. Or if you use usual available high-intensity statin plus ezetimibe plus PCSK9 inhibitor, you can achieve a reduction of 80%, and thereby you can achieve an ultra-low target of LDL. And these recommendations continued. And then now, before we were having kind of only statins as the backbone of therapy. We still believe that, but nowadays clearly in the guidelines it is shown that as general concept, the task force recommended to add non-statin therapies with proven cardiovascular benefit, such as ezetimibe, PCSK9 antibodies, or bempedoic acid, taken alone or in combination, to lower LDL cholesterol if the LDL cholesterol goals are not achieved with the maximum tolerated dose of a statin, which is often the case. And you can't achieve less than 40 just by giving a statin. You have to give a non-statin. So in order to achieve a good goal, you have to resort to the non-statin therapies and the powerful non-statin therapies like evolocumab. And then again, the rethinking the approach, substantial LDL cholesterol is essential to maximize cardiovascular benefits in first-year post-MI patients. So now the concept is that as soon as you have a patient, high risk, an acute MI patient, you start thinking rigorously, immediately, aggressively, and treat and try to bring down the LDL as fast as possible. And so the treatment starts there. And same came with the 2025 ACC-AHA guidelines for the management of patient with ACS. They also said, look and examine the patient. Within 4 weeks, if you are not reaching to a target, start PCSK9 inhibitor. And now latest, we have the ACC 2026 dyslipidemia guidelines, which time and again continued to maintain the position, or rather increasing the position of PCSK9 inhibitors as a part of the therapy, and early initiation of PCSK9 inhibitor in both in high-risk ASCVD patients or in situations where there is primary hypercholesterolemia or patient with acute coronary syndrome. So we often have these kinds of situations, and we should look at these cases very carefully. We believe that angioplasty is the panacea, and we treat the patient with an intervention, open the artery, everything is good, but not. That alone is not enough. So these all are real patients. This is the second case beside the first one which I showed. So 53 years old male, old myocardial infarction twice in last 5 years, resistant hypertension, mixed hyperlipidemia, diabetes, LV dysfunction, tachyarrhythmias, stroke, everything here. And his pre-treatment lipids to us were not available because we did not know by the time he presented to us. But he was having rosuvastatin 40 and fenofibrate 145. His last 3 LDLs were still 92, 110, 110. I believe the target for this kind of situation is less than 14. As low as if you reach to 15, 20, 25, doesn't matter. Everything is better for him, whatever lower you go. And this patient's 100% would need a substance like evolocumab or PCSK9 inhibitor. And similarly, the case like this with old myocardial infarction, primary PCI on already statin plus ezetimibe, muscle aches, pains, not reaching to the LDL targets, at least we should go below 55. Better even if you go below 40. So next step, without hesitation, should be a PCSK9 inhibitor. So what do we learn with all this? So evolocumab to achieve ultra low LDL targets, it's a very, very important medication. It reduces LDL cholesterol as much as by 61%. And you'll be surprised and amazed that the LDL actually goes down within 1 or 2 weeks. If you check the patient sample after giving the medication within 2 weeks, you will see a significant reduction in the LDL. The cardiovascular outcomes by 53% over 1 year. It is safe and well tolerated, and also needs very early initiation in the patient with acute coronary syndrome. So with this, thank you so much.
Thank you very much. Is it working?
Yeah.
Thank you, Dr. Mittal, for the timely and concise presentation. It was an interesting topic, and as we know, LDL is a major modifiable risk factor in coronary artery disease. Lower is better and sooner is better. As we know, 2026 guidelines has pushed back the age to 30 years of cholesterol treatment instead of 40 years. My question is, how soon and in which category of patients do you start evolocumab? Like, do you keep it only for very, very high risk patients, or you use it in moderate risk patients with statin side effects?
So targets are nowadays well defined. If you have, I'll give you a scenario. If you have an acute MI patient today, already on statin or ezetimibe, not on the target, you will start on day one, PCSK9 inhibitor. But if patient is naive, he is not on any statin, first time coming, then you start statin ezetimibe. Within 4 weeks, you check, and if patient is not controlled, you start PCSK9. So this is how we go. In familial hyperlipidemia, primary prevention, obviously we treat with the statin and ezetimibe first. If not controlled, you start PCSK9. So,
thank you.
Yes, doc.
Yeah, just to add one more thing. Before even some patients, before putting to evolocumab, I have tried many patients to put him on a statin, high dose, bempedoic acid and ezetimibe combination of 3. And when we followed up these patients, about 20-25% of patient has reached the target. But still there is a big gap of about 40 to 60% they are not reaching in spite of the 3 drug. And then we have to switch to the evolocumab.
That's right. Dr. Laila.
Thank you, Dr. Mittal, for this presentation. We all know that the lower is the better, but my question is, what about the other systems in the body, like the brain and the muscle and the other organs? Do they like lower cholesterol as low as that? As a cardiologist, yes, we like it. The heart likes it because we reduce, based on this studies, the risk of all the MACE and things in the studies that is shown. But what about, we have to look at the patient as a holistic approach. I mean, is there any study that shows if the LDL was 20 or 30 and milligram, and we followed up the patient for 10 years, are they more prone to, for example, diabetes or Alzheimer's, for example? Are the things? Thank you.
So your question is very valid, but time and again, all the meta-analysis of all the trials, and including those which have reduced LDL very, very low, like Fourier trial, like trials with inclisiran, none of the trials actually has shown any, as compared to control group, any long-term bad effect of lowering LDL even less than 20. So nowadays, this is out of our question. We have to explain to our patient. We didn't conduct the trials. Trials clearly have shown us anything lower is fine and it is not affecting any other system. Unlike blood sugar, you can't lower at below certain level, but not that doesn't apply with LDL. You can go as low as possible. We have patients on 20, 25, 24, 18, and we are just happy with them and we are continuing with them. So
Dr. Mittal, one question.
Just a comment. Regarding this cognitive impairment, there was a dedicated study in Fourier which looked after the cognitive impairment, and those 25% patients who had an LDL less than 25, there was no difference. So this is all myth. High intensity statins along with non-statins try to achieve lowest and longest is the best. So that's what should be followed.
Dr. Mittal, one question I have. Thanks for a nice presentation. In the Fourier trial, we saw there was an LPA, the lipoprotein A was reduced by 20 to 30%. Do you attribute this cardiovascular risk reduction to only LDL or to decrease in the lipoprotein A?
Well, this is not established yet. And we have another talk on the same phenomena in the evening, which also includes LPA trial and the Vesalius trial. So we'll get that answer. But the primary thing is this is the LDL which is causing the reduction, because not every patient had high LPA. Not every patient had high LPA. Even those got benefited, those who were having normal LPA and their LDL was
But the
reduced.
group which had high LPA, they got more benefit as compared to the patients who had
Right,
only.
right. That's right. Thank you. So I
Thank you.
To Dr. Mittal.
Yeah, thank you.
I have two questions. Excuse me.
Who?
Yeah, here. I have two questions.
I'm sorry, please, we want to close the session for the
Yeah, I think we are now at the end of the time limit. We have more good talks coming up. I think we should give time for that. This is definitely a very good topic that we have gone through, and I hope we've all take home some good messages. And thank you all once again.
Thank you. Thank you so much. Yes, please. Dr. Srinath. Dr. Kapoor. Dr. Sai. Dr. Patil. Thank you, Dr. India. Thank you. Thank you. So we are extremely sorry for not able to take up so many questions, but so you can always discuss in the break times. We have to respect the timing actually. Already we are slightly behind the time. So now we have session 5 and 6 for which I call upon the chairpersons, Dr. Rajesh Pancholia, a consultant interventional cardiologist, a good friend for a long time in Dubai. So Dr. Rajesh, and then we have Dr. Perfensco Corvo, is the first timer in our conference. So we welcome him as a faculty, maybe next time as a speaker. Welcome. Thank you. Thank you, Dr. Rajesh. Welcome. And our third chairperson is Dr. Amrish Agrawal for this session, and Dr. Abdullah Al-Hajri. Dr. Abdullah Hajri is consultant in Dubai and is also a dear friend. Most welcome. Dr. Amrish, consultant in Fujairah Hospital. Please, session is yours, and please respect the timing. That's all I demand. Thank you.
Good afternoon, everybody. And today we are going back to the bench. We can say we're rather to the bench, to the basics, and talk about hypertension, which we've been treating for decades since we started practicing medicine. And I have pleasure to invite my colleague from my hospital, Dr. Tahir Gujim, who is an intervention cardiologist at Fujairah Hospital. He's going to talk about preventing the patient going to the cath labs, obviously treating the hypertension early. So his title of talk is Revisiting Telmisartan, Efficacy, Safety, and the Metabolic Agent in Hypertension.
Good afternoon, ladies and gentlemen. Thank you, Dr. Amrish, for your nice introduction. And thank you, my colleague, Dr. Mittal, for inviting me. And in advance, I congratulate you for the success of this wonderful meeting. So without further delay, because we are out of time, I'll speak about the use of telmisartan and the management of the hypertension by revisiting telmisartan, the efficacy, safety, and the metabolic age in hypertension. And this is important, particularly when we know that the prevalence of hypertension in the Gulf countries is almost 3 in 10, almost 1/3 of the population having hypertension, being highest in Oman, and in United Arab Emirates, at least 30% of the population of hypertension. This is important to know that the problem is not only because the disease is prevalent, but the problem is that it is difficult to control this blood pressure when we know that all over the world, more than 280 million people have hypertension, but their blood pressure is uncontrolled. And there's data showed that approximately 1 in every 2 women and 1 in every 2 men receiving the hypertension medication, but unfortunately their blood pressure didn't reach the target. And the reason behind that, why people, they have hypertension and their blood pressure didn't reach the target, and I can summarize it probably into a few points. The first one is adherence problem, and we know that particularly a cardiac patient, they have multi comorbidities, so they are using diabetic medication, thyroid medication, dyslipidemia medication, so very difficult to keep them adherent to their antihypertensive medication. The second one is the patient is using antihypertensive medication, but unfortunately the doses are too low. So the people, they are not escalating the doses to reach the target. The third one is absence of synergy. So sometimes people, they will give antihypertensive medication, for example, alpha blocker with beta blocker. So there is, according to the guidelines, there is certain medication should be combined to have a synergistic effect to achieve better control of blood pressure. And finally, the clinical inertia, when we are as a physician or medical staff failed to escalate the antihypertensive medication to reach the target for every patient. So how we can solve these potential causes? So I will speak multiple times on what we call the rule of 10. So what's the rule of 10? Simply, how you know how many drugs you need to give for your patient to control blood pressure. First of all, approximate number of medication needed to achieve the patient target blood pressure, this is generally speaking, can be calculated by current systolic blood pressure minus target blood pressure divided by 10. For example, if the patient blood pressure is 160, so 160, and you need to reach the patient 130, so 160 minus 130, it is 30, 30 divided by 10, so 3 drugs. So most of the time, we can use this rule to simplify how many drugs you need to give your patient to reach the target. Second rule of 10, that if you double the dose of your antihypertensive medication, you will get only 2 millimeter mercury reduction in the blood pressure. However, if you add another medication, particularly with a synergistic effect, you will get 10 millimeter mercury reduction in the blood pressure. Another 10, 3 out of 10 population, they lack the adherence to the medication. Many of our patients, we give them multiple antihypertensive medication, but gradually they will become non-adherent and they will even stop the medication. Some of the medication twice daily, they will receive it only 1 daily. So these are main causes of failure to control blood pressure. So how we can manage these patients? Before starting and discussing the role or the protocol for the management of hypertension, just I want to remind you about the European Society of Cardiology guidelines regarding hypertension and how they define the hypertension. So any blood pressure less than 120/80 is normal. More than 140/90 is hypertension. Between them, we called it elevated blood pressure. All the guidelines, and they recommended single pill combination. Usually they recommend combination of SOR plus calcium channel blocker. If no improvement, then you can combine 3 of them, SOR plus calcium channel blocker, the diuretics. If no improvement, then you can add spironolactone, MRA, alpha blocker, beta blocker, any medication. If you fail, then at that time you need to refer the patient to the specialized hypertension center. Why single pill combination is important? Because they found that if you give the patient single pill combination, you will improve treatment adherence by 15% and you will reduce treat time to achieve the target by 28%. Definitely, because you are giving multiple drugs that have multiple mechanism of action, so you can reduce the blood pressure early. And not only this one, if you give the patient single pill combination antihypertensive medication, you will get 21% reduction in the 1-year risk of cardiovascular event and 39% risk reduction in the risk of the ischemic heart disease. And usually the cardiovascular diseases are continuum of the diseases, not only one step. And this continuum started by the risk factor. Hypertension being the one of the most strong risk factor for the development of the cardiovascular disease in general. So basically, there are multiple risk factors, including diabetes, hypertension, dyslipidemia, smoking. These risk factors gradually lead to the development of left ventricular hypertrophy, myocardial infarction, remodeling, heart failure, and unfortunately ended with the increasing morbidity and mortality. So our aim is to enter the cardiovascular disease continuum by achieving, first of all, early diagnosis and trying to tackle the risk factor rather than the treatment of the disease itself. Particularly, we know that 32% of the mortality worldwide caused by cardiovascular diseases. And again, rule of 10, when there is an increase in systolic blood pressure by 20 over 10 millimeter mercury, this will lead to an increase in the ischemic heart disease and other cardiovascular disease. So once the blood pressure increase 10 over the target, you will actually increasing the risk by doubling the fold. So for example, the blood pressure when 35 over 85, there is an increase in the risk of the cardiovascular disease by twofold. Blood pressure increased more to 155 over 95, the risk factor, the risk to have cardiovascular disease will become fourfold. Again, any increase in systolic blood pressure by 10 millimeter mercury, this will lead to an increase in the risk of the stroke by 45%, ischemic heart disease by 45% and stroke by 65%. So just to summarize the rule of 10 millimeter mercury reduction in systolic blood pressure, you will have result in major cardiovascular disease event by 20%, coronary artery disease by 17%, heart failure by 28%, death from all causes 13%, and stroke by 27%. And without going into details of this slide, all of us know that RAS system play a major role in causation of the hypertension and unfortunately later on in the development of the comorbidities. So there are multiple drugs that can tackle this pathway, including angiotensin converting enzyme inhibitor or angiotensin receptor blocker. But if you focus mainly on angiotensin receptor blocker today, and it shows how can protect the cardiovascular disease, there is a meta-analysis of 4 trials, and this large number of the population, more than 16,000 patients in this trial, and when they compare the angiotensin receptor blocker with other control, and clearly showed that angiotensin receptor blocker in general reduce the risk of stroke, reduce the risk of the coronary artery disease, heart failure, major cardiovascular event, cardiovascular death, and total mortality. This gives the indication of angiotensin receptor blocker more than other drugs in controlling of blood pressure. The same said for comparison of angiotensin receptor blocker with angiotensin converting enzyme inhibitor in multiple meta-analysis trial, and they showed that stroke reduced by 8%. All the trials, most of the trials actually showed that angiotensin receptor blocker reduced the risk by 8% in comparison with angiotensin converting enzyme inhibitor, which means that probably in order to prevent stroke in hypertensive patient, the best drug is probably angiotensin receptor blocker. And one of the good combination available in the market is combining, as I said, angiotensin receptor blocker with a calcium channel blocker. Is a combination of telmisartan with amlodipine, either 80 over 55, 80 over 10, 40 over 5, or 40 over 10, telmisartan plus amlodipine. And why this combination is very good, because if we look to the benefit and side effect of both drugs, it is almost overcome by each one of them. For example, calcium channel blocker, amlodipine, it causes arterial dilatation. Unfortunately, it causes some peripheral edema and effective in lowering the low renin patient, but it doesn't have any effect on RAS activation, and it has no benefit on renal or heart failure patients. The same drug, because containing angiotensin receptor blocker, this is overcome the side effect of the amlodipine, because it has a balanced dilatation of the arterioles, and it reduces lower limb edema. So if you combine telmisartan with amlodipine, the blood pressure controlled more, it has more effect on reduction of the cardiovascular event, and at the same time, it can reduce the side effect of the amlodipine by improving. Again, a patient with telmisartan amlodipine, if you compare it with amlodipine 10 milligram, so telmisartan 40 or 80 or plus amlodipine 5, or telmisartan 40 or 80 plus amlodipine 10. In amlodipine 5, 80 over 5, there is 90% reduction in lower limb edema if you compare it with amlodipine 10. However, if you give the patient 40 or 80 plus amlodipine 10, there is a reduction in lower limb edema by 71%. So in both combination, whether the amlodipine 10 or amlodipine 5, there is significant reduction in lower limb edema, but definitely when the amlodipine 5, the reduction in lower limb edema. So just the last 2 slides for me, because the time is going. This is a case a 59-year-old gentleman admitted to our hospital. He's a smoker, and he's hypertension on amlodipine. He's dyslipidemic and little bit obese. He admitted to us with acute pulmonary edema due to high blood pressure. If you see the blood pressure, the first time is 160 over 125. Then that time, the first two readings, it's high. Even the diastolic blood pressure is high, more than 100. Particularly this patient, he have heart failure. I mean, pulmonary edema, so definitely you have lower limb swelling. So we use this choice to control the blood pressure and to improve his lower limb edema. So the last slide for me, just try to keep your patient according to this watch. In the green light, the blood pressure of the patient should be less than 130 over 80. Thank you very much.
Dr. Taher, thank you very much for highlighting the danger of hypertension. And it's a slow disease. I mean, you wouldn't know what the damage occurs over the time, and eventually it manifests in the cardiovascular manifestation. And more importantly, thank you very much for finishing your time, giving Dr. Mittal little more space. So if there are some questions from the audience, Dr. Taher, will you happy to take them?
I have a question. Congratulations for the nice presentation.
Thank you.
I'm a fan of telmisartan, especially with the association with amlodipine. My question is, according with the guidelines, with the target that we have for blood pressure now is 130/80, with the new medication that are coming, with the renal denervation in the guidelines, what do you think is the role of this medication in practice when we are facing patients that are not adherent to the medication?
Yeah, this is a very good question. It's a practical question. That's why the guidelines, they focus mainly on the single pill combination. And we see actually in our clinical practice that many of these patients, they didn't reach the target because they are using multiple medication. So in clinical practice, we found, to be honest with you, the Twinista, particularly 80 over 5 or 80 over 10, very potent drug. I think most of these patients, I didn't have any patient on a Twinista without reaching the target. This drug probably will be part of management of every patient who have at least uncontrolled hypertension. The guidelines actually focus on combination, but I think the combination available are too much in the market, but you have to choose the drug that is effective. I think telmisartan in general is the one who's playing a major role in this combination to control blood pressure.
Thank you. One more question from my side. Yes, doctor. One more question from my side is that the telmisartan has got a gamma PPR action also. It's a gamma PPR agonist, like pioglitazone, so similar to that. So do you think some actions regarding the metabolic can come from the gamma PPR?
Yeah, there is many trials to show that it is beneficial even in metabolic syndrome patient and have some metabolic effect. Maybe I didn't review all the data regarding this topic, but this drug have a multiple effect, not only to control blood pressure, but has many multiple effect even in metabolic problems.
Thank you very much, Professor Amrish, for the moderation, and Professor Thaer for the wonderful talk. Hypertension, unfortunately, still is among us, 1.28 billion people globally, unfortunately. And we have every medication in the book, but still the issue is still among us. So could you please kindly comment specifically with telmisartan? Yes, we do know that it's usually having the longest half-life from all the ARBs, giving it the 24-hour protection. But could you please kindly comment on the blood pressure variability, especially with this medication? Because blood pressure variability, as you already know, is one of the current things to endure when you're basically prescribing a antihypertensive for a hypertensive patient. And if we, I'm not going to go into the debate of ARB versus ACE, but could you just also give us a small comment on the, for example, like comparing ARB to ACE in terms of certain population, elderly, CVAs? So I would love to hear from you from that. Thank you very much.
Yeah, so the slide shown that telmisartan amlodipine has a benefit in multiple subgroup of the patient: diabetic, obese, metabolic disease, old age patient. But be careful, because telmisartan in very old age patient, telmisartan is a potent in general. Telmisartan is a potent antihypertensive medication. So if you don't want to lower the blood pressure suddenly, be careful. Otherwise, telmisartan amlodipine, it has very, very good, let us say, benefit in controlling blood pressure. The second issue regarding variability of blood pressure and what we say dipper or non-dipper, I didn't go in details because of the time, but probably this drug can show a very good result in people who has non-diabetic blood pressure, when they have blood pressure is high even in the early morning. This is have a wide range of benefit, very potent antihypertensive medication. The slides and meta-analysis show this drug has a benefit in different, let us say, phenotypes of the patient, particularly with hypertension.
Blood pressure variability, that's the number one. This reduces central aortic pressure, that's the number two. And this reduces metabolic complications and have a very significant metabolic favorable effects. In pre-diabetes, this can be used. It does not lead conversion from pre-diabetes to diabetes, which others can lead to as major problems. So that's why, in three aspects, this combination is quite.
Thanks a lot. I think we have to move on. Thanks a lot, Dr. Tai, for your speech. Now let's start with the session number 6, reimagining healthcare. It's my pleasure to invite to the stage Dr. Laila Al-Marzouki, consultant cardiologist, King's College Hospital, London.
Thank you very much for the introduction, and congratulations, Dr. Mittal, for the 10 successful years of having this conference, despite of all the difficulties going around at the moment. So today I'm going to talk about a topic which is really related to women, and it is a very important topic, and I hope that my all the chairperson here, they're all men, I hope they will agree with me now. Okay. How do I change it? Okay. I would like to start my presentation with a case study of the clinical case of 52-year-old woman who presents to ER, and she presents with nausea, fatigue, and shortness of breath. All investigations are done, and then she's diagnosed with anxiety, and she is discharged. I mean, this case, a lot of you might have came across this case in the past, but then 2 days later, the patient returns with myocardial infarction. If man and woman, if a man and a woman present to ER with the same cardiac case, men will be treated based on decades of guidelines. But women, she may not be treated exactly according to the guidelines that will match her profile and will match her risk factors and will match her gender. We treat women according to guidelines that we tailor to men, but still we call it evidence-based medicine. So women, unfortunately, they are misdiagnosed sometimes and undertreated, and they are underrepresented in many clinical trials and guidelines. So do we need women-specific cardiology guidelines, and can AI help closing the gap? And are gender-specific guidelines enough? So I'm going to tackle these questions during my presentation. So women usually, they are often, not usually, but often they are missing the good clinical cardiac care because the guidelines and the medication have failed to address their needs. And they are, as I said, underrepresented in the guidelines. Women, they usually have risk factors that might be unique to them compared to men. For example, during their pregnancies, the gestational diabetes and the hypertension in pregnancy-induced hypertension, preeclampsia, and prepartum cardiomyopathies. And also, they have other unique risk factors like polycystic ovarian syndrome, which are associated mostly with diabetes type 2. And we know that the breast cancer survival, they are more prone to cardiovascular disease, plus the autoimmune diseases, the women are more prone to these things like rheumatoid arthritis, for example. And we know that the traditional risk factor, cardiovascular risk factors like hypertension, diabetes, chronic kidney disease, and physical inactivity and depression, they have more burden in women if we compare it to men, and they cause higher risk factor for women compared to men in terms of causing coronary artery disease. And not only in the risk factor, but also in terms of medications and devices. We know that women, they are more prone to side effects for certain medications, for example, like ACE inhibitors, and they're the same for other type of medication. Like, for example, women are more prone to resistant to clopidogrel by genes, for example, as per the study has shown. And women has been excluded from the research and the guidelines because of some factors that studies had looked at it. For example, the childbearing age and pregnancy and lactation. This leads to women not being included in the guidelines. And while I was researching and reading about this topic, interesting enough, I found out that even the chairperson in many randomized controlled trials, they are male, unfortunately, or fortunately, but the women are really, their number of being as a first author is low as well. So is that the other cause for that? We don't know. So the thing is, even women, we know that they present atypically compared to men, and they present later than men. But then they lead to the diagnosis not to be taken seriously as compared to men. So these are some examples of some clinical trials that even in 2025 and 2026, that there are severe presentation of women in these clinical guidelines. And in some of them, even women, they are women were only 1 in 4 participants. And that leads to women underrepresentation in randomized control trial and diagnostic bias, unfortunately. So the question is, are female-specific guidelines enough, or do we need more than guidelines? Do we need women-centered cardiovascular system? So guidelines and system is the answer. So we need them both. So we need dedicated, independent clinical system tailored specifically to women's biology and risk factor that addresses their chromosomal, hormonal, and reproductive influences across the woman's entire lifespan. From the young woman to middle age and to post menopause. So it's kind of like a holistic approach, multidisciplinary approach. We need the cardiologists, and we need the obstetricians and gynecologists on board with us, and plus the endocrinologists to address all their needs and all the risk factor that they're going through. So how can AI help, and can AI bridge the gap, since the evidence gap has gender, unfortunately, and many guidelines mention them late or mention them very superficially. And the problem is not that the women are not underrepresented because evidence is absent. They are underrepresented because medicine has not learned how to see them properly. So AI is coming in, and we are concentrating on the precision medicine as well. So the question is, no, how to treat a woman? No, but the question is how to treat this woman. So this is something that I thought about, the female evidence pyramid. So the male drive evidence, we move from that stage to a lower part, to upper, to upgrade to limited female RCT representation. And we look at to involving AI in the care of women to precision female cardiology. So I would like just to give you an example in real case. So we have a 57-year-old lady who comes into the emergency, and she's obese and has got history of hypertension. She comes in with fatigue, exertional shortness of breath, intermittent chest pain, and she presented 3 times to ER over 6 months. So the traditional approach to that we used to do is the standard ECG interpretation, and we say that the ECG is unremarkable and it doesn't have any specific changes, and then goes to the routine echocardiogram, and we focus on the ejection fraction, and then we go, maybe the patient goes to the coronary to do coronary angiogram, and we saw that there is the coronary angiogram, there's no coronary artery disease shown on it, and there's no obstructive coronaries there. So what we do is we attribute her symptoms to anxiety and menopause and depression and deconditioning, and we reassure the patient, and then we give her general advice and symptomatic treatment. But unfortunately, in this way, we're delaying the diagnosis, and the patient comes back again and again and repeat ER visit with the same with the same symptoms. But if we apply precision medicine and AI approach, so what we do is the ECG is read by cardiologists, and then the AI help us in interpreting it, and then it shows the subtle hidden signal of diastolic dysfunction or the HFpEF risk, and then AI enhance the echocardiography and then see the subtle strain abnormalities and the early dysfunction and the filling pressure that the patient will have. Then we will put all of these things, the finding plus her history and the examination and her risk factor, and then we get into personalized treatment based on the phenotype AI integrates, and then the early recognition of hidden disease, which is the heart failure preserve ejection fraction, and all you know that this is kind of regularly or very often is missed for female, which is very common condition, is often missed. And then we go into the precision treatment for this lady, and then we look at the hidden contributing factors as well, like sleep apnea or atrial fibrillation, and we give her the treatment based on whatever she has for her hypertension, for her obesity, and for we give her exercise prescription. We will not say just go there and be more active, but we will give her a structured cardiac rehabilitation that will match her, and we do a tailored follow-up for her. And this is precision medicine. So we're moving from traditional model of normal test, dismiss symptom, and repeat ER visit to AI-enabled precision cardiology, which is hidden phenotype detection, earlier diagnosis, and personalized therapy. So in summary, women are usually not underdiagnosed because their disease is rare, but they're underdiagnosed because our system were not designed to see them. And the question is no longer whether AI belongs into women's cardiology, but the question is how can we afford not using it. And for decades, unfortunately, women were expected to fit into cardiology. The future of cardiology is cardiology finally fitting women. And the greatest risk factor in women's cardiology is they should never be like being a woman. Thank you very much.
Thanks very much, Dr. Leila, for this great lecture. So if anyone has a question for Dr. Leila. Dr. Mittal.
Thank you for an excellent presentation. So how do you foresee in the coming future, for example, in our part of the world, to actually being used practically and the way you think should be applied in daily practice?
The precision medicine and gender-specific guidelines, I think, and having the AI in our clinical day-to-day practice, I think, is the future. Because now what we're doing, we're still practicing the traditional medicine and that we used to practice 10 and 20 years ago. But now I think what we need to do is we need to get AI into our daily practice. It might be not affordable everywhere in all the hospitals and in all clinics, but at least in the specialized tertiary care, that is where the AI will come into play, where we can detect diseases earlier and more, and then deliver personalized and precision medicine for all of our patients, not only female, but male as well, based on customized care that we develop for them. And we need to develop system for this that accommodate for that as well.
Just a question. As you said, the data was fed into the AI model and which detect the hidden phenotype of HAP-PAF. Your patient was obese, hypertensive, presenting with dyspnea. And if you just implement S2F PAF score, she is obese, she is hypertensive, there is evidence of increased filling pressures on echo, just get an NT-proBNP, your patient will qualify for HAP-PAF. It's just a question of having a high index of suspicion.
Exactly, especially that these patients don't present to cardiologists as a first time, so they go into ER or they go to see their family physician. And as you kindly mentioned, the suspicion for women at this with all these risk factors for HFpEF should be very high. And anytime any doctor, internal medicine or family medicine suspect that, they should refer to a cardiologist.
Okay, thanks very much, everyone. I think we're running out of time now. Thanks very much, Dr. Leila. So next lecture is going to be very interesting since we are in the AI era. I'd like to welcome Ms. Renita Das, she's a founder and CEO of Renita, and she's going to give us an interesting lecture. Reimagining Healthcare. Are we ready for doctorless job? Doctorless care.
Good afternoon, everyone. Thank you, Dr. Brajesh, for inviting me to this Shakeheart conference. Congratulations at such an amazing event. I am not a cardiologist. I want to say that straight out. I don't have any fancy letters behind my name. But what I bring to the table is 30 years of experience working across 10 countries of the world with C-suite, looking at disruption, innovation, and leadership with healthcare organizations. So I've worked with doctors, clinicians, I've worked with the peer system, I've worked with hospitals, clinics, labs, I've worked with manufacturers, I've worked with distributors, I've worked with all parts of the ecosystem to understand how do we bring about digital and disruption to healthcare. So I've seen a lot of lessons that have worked very well, I've seen a lot of failures, and I've seen a lot of things that have gone by the wayside. And today, what I'm here to talk about really is how do we rethink the system of healthcare in light of everything else that is happening in the world. The future, if I look at the future, a lot of my work is focused on the future of health now because, as you probably know, there's so much of digitization that's happening. And Dr. Leila, talked about it so wonderfully in terms of what's going on in women's health. But if I look at the future of health, I really don't look at it from the future of technology. We focus too much on technology, on the tools, on the drugs and the devices. I look at it more from the future of people that are in the system and how are we adapting to the environment of technology and how are we looking at some of the friction points in technology. So the future for me for cardiology doesn't start with technology. It starts with a moment. And I want to share a little story with you that will help you to think about whether we're asking the right questions or not. And that story goes back for me almost 15 years ago in 2010 when I was working with Kaiser Permanente in California. I don't know if you've heard that name. It's a very large HMO based in California, and I was working in some transformation in their OR suites. And one day the CEO, Dr. Bernard Tyson, he was an enormous, remarkable man in the United States in terms of bringing in new concepts of care into the system. He called to see me in his office, and I was very, very worried as to why he had called me to his office. And he just asked me a simple question. He peered down at me and he said, "How do I make more money?" And I just couldn't understand what he was talking about. I said, well, I talked about the dashboards. I talked about the KPIs. We were meeting all the numbers. So what's the problem? So he said, no. He said, how do I make more money by keeping my patients, which is 1 million of them today, outside the four walls of my hospital? So I took a deep breath and I said, let me get back to you. Let me think about it. And keep in mind, this was the year 2010. It's far, far behind Obamacare, value-based care, and all the new innovations that the US had brought into the system of healthcare. So I came back after 2 weeks and I asked him a very simple question, which would really change the future of that hospital, Kaiser. I asked him the question of, what business do you want to be in? You're in the business of sick care today. You're looking at keeping people sick. If you want to be in the business of keeping people outside the hospital, you need to change your business. And he said, I never thought of it that way, but yes, that's the business I want to be in. So how do we make that happen? And that was the genesis of what we call the famous award-winning campaign called Thrive, that has now been followed by over 5,000, 10,000 hospitals in the world. And what Thrive did was, we did not only change and create a publicity campaign, we changed the entire workforce. We changed the entire clinical environment. We changed all the metrics, the KPIs of how do we measure success? How do we measure outcome? What is the outcome are we looking for? The outcome we are looking for is healthy, not sending a patient back home after 3 weeks in the hospital. And so everything had to be changed. And so the reason I bring that up is that we really need to ask the right questions today. And I'm here to talk about a concept of doctorless care to you. And here again, we need to be thinking about what is it that we're looking for in doctorless care? Because if you're talking about an argument of, is doctorless care better than the human? It's a foolish argument in my view. So we really have to think about what matters at this point, and are we using the tools and technology for the betterment of the human that we are treating across the desk or the table? So that's what I'm going to talk about today. Basically, the story is about reimagining care and health. And the question that I have to all of you is that we are seeing a huge revolution of wearables that are taking place in the world today. There is a wearable for every single body part, I calculated. Just recently, I found a wearable for stress. It's a company that's coming out of Stanford University in California. They just raised $20 million. They're able to test 24-hour stress levels of free cortisol non-invasively. So very soon, this will be accessible to many people in the world. Yesterday, it came to me that there is a company in Korea that's producing a cuffless blood pressure monitor ring that you can wear 24 hours on your finger, almost just like the Aura rings that they're using. And it has been approved in the US, Europe, and Germany. It's called the CART, C-A-R-T. And it's right now going to be used. So the question that I have to all of you is that the first clinical moment that a patient will be looking at is not going to be a human anymore. It's going to be an algorithm. It's going to be a signal. It's going to be a flag. It's going to be an alert. We already have that in our watches, in our, some form of wearable device that we're using. If we look at the consumer revolution that is taking place in the world today, healthcare is just one facet of our lives. Every other facet of our lives, we're using some form of a connected technology. 60% of people in the US are using some form of connected wearables for their health. I was amazed at this statistic regarding India. 33% of Indians are using some form of wearable to track some measurement of their health. And globally, the number is 1 in 10. So it's a pretty high number. In studies that we've looked at, almost 80% of people would trust an AI for the first triage. I just completed a study regarding diabetic retinopathy testing for the eye for type 1 diabetes patients. And we asked them, and this is a global study that was done, we asked them, the patients directly, would you prefer an AI diagnosis as the first step followed by a doctor looking at your results, or would you prefer directly a doctor's appointment? And 78% of them said they would prefer an AI as the first diagnosis. So we're having a huge push by consumers who are looking for AI as the first diagnosis, as the first form of triage. So what we are going to be seeing by 2040 is that the algorithm is going to become the first touch. The algorithm is going to become the surveillance tool. And as a result of which, the cardiologist or the specialist will have to reskill themselves in terms of becoming a system architect. They're going to be the designer and governance of that system. So the tools and role will change. And this is really what I'm going to be talking about in this presentation. So we're not talking about less doctors. We're talking about doctors working differently. We're talking about metrics that will change. And we're going to talk about how we can make that transition to make that happen. So how will your role change? That's the basic question that many of you might be asking me. If AI is going to take on, let's talk about it from a very basic level. AI is set to change the world for precision health. We haven't seen any outcomes of AI yet in that aspect. $40 billion have been spent in terms of drug discovery by pharma companies for AI. We don't have a single AI-driven drug yet. But what we do have is we have a lot of evidence and a lot of outcomes of AI doing a fabulous job in terms of routine work, in terms of following up, in terms of alerts, in terms of documentation. We heard earlier this morning about the use of AI in ECG reads and in terms of early flagging. So risk assessments, AI is doing extremely well. So why don't we use AI in our practice to be able to start doing that, which is doing so great? So what would the role then of a doctor be? It's going to be focused on more the serious stuff that needs more analysis, that needs more thinking, rather than the routine stuff of filling in spreadsheets and forms and administrative paperwork. So we're looking at complex judgments. We're looking at multi-modality patient decisions. We're looking at pathway designs. We're looking at system governance. So a lot of change in the role. So what we are seeing is that in 2040, cardiologists need to think about spending only 20% of their time doing routine work. All of this should be done by AI in the systems. 50% of the time doing much more complex ideation and complex judgment with the patient, and 30% really thinking about whether the results were right, the validated, all of that. So it's a very, very different role, and slowly we have to open ourselves to be able to make that change. So what does the cardiology clinic of 2040 look like? Now, I've taken results from two clinics that I've personally been a part of in the US and in Singapore, and we've seen the advantages of some of these clinics. So what we're looking at is a patient journey that is really starting with the wearable. Many a time, these wearables, patients are collecting themselves. You know, the Apple Watch already has wearables on them, and now we have all these newer wearables. Dr. Leila was talking about women's health. Today, there's a wearable that is being able to track your hormones on a regular basis. Hormone changes and fluctuations are one of the leading causes of cardiovascular disease. So there's a lot of data that we can use that we're not using today. So in terms of the patient journey, we're talking about really the journey comes to the doctor when all the data is there. We're not spending a lot of time focused on getting that data. Right now, what's happening in a doctor consultation, we're spending all the time in discovery and in diagnosis. We're getting the longitudinal data. So really, we're taking more time in being able to have FaceTime with the patients. I'm just going to skip because the time is up, but just wanted to tell you the two results of this. 48% higher, 41% higher in terms of patient satisfaction, much more engagement of a patient, and much shorter visits, so you can see more patients within the time and have it much more accurate and targeted. Obviously, the Middle East is having a huge propaganda and development towards having AI in their diagnosis, almost 40%. There's a need for high digital readiness already there. So it's already working, and we've seen wonderful results from Cleveland Clinic and others in terms of the success factors of using AI. So I'm just going to skip this. This is giving you data of some of the tools that currently are needed and the fact that cardiologists feel that they don't have enough training to do this. But we're really looking at 4 new skills: probabilistic thinking, algorithm literacy, human AI communication, and population design. So really in the final moment, what I really want to talk about is not what role you're playing today, but how we need to change the metrics. This is giving you an idea of some of the metrics that we need to start thinking about. And one of the biggest metrics we're looking at is patient engagement, because we know that the more engaged the patient is, the better is going to be the outcome.
Dr.
So finally, I just want to just end by saying that we have to also know when is the right time to use AI and when is not the right time to use AI. Trust is something that can't be coded. Trust is something that has to be earned. Judgment is something that we know how to act for the right reasons. Obviously, empathy is about the whole aspect of caring and becoming more human. And I think it's all about change management, which starts at the top. So we need to use AI and use technology to become more human, not to be less. Thank you very much.
Thanks very much, Dr. Renita. This is really a nice and excellent lecture. So I don't think we have much time, actually. If anyone has a question, maybe during the lunch break, you can ask Dr. Renita. And now, actually, we're heading to the opening ceremony. And Dr. Mittal.
So before we end this session, we'd like to felicitate our speakers and moderators. So please, can you help me, guys? So we have Dr. Laila, please come over. Wonderful talk. Different perspective. Dr. Thai. Thank you so much. Dr. Abdullah. Thank you, all the speakers and moderators. Now, please bear with us before lunch, about 15 to 20 minutes. We'll have some felicitation and not a very formal inaugural ceremony, but at least some kind of ceremony to felicitate and to reward and award and appreciate our distinguished guests and faculty. So may I request Jitin and team to start? Can you lower down the lights and play the video?
So, yeah. So, GC. Shaped by purpose to save lives. Tax effect across the world. Every case is a person, a family, and a moment where timely action matters. SHAKE stands for a complete heart care mission, preventing heart attacks before they happen, ensuring timely treatment when they occur, helping prevent future attacks after recovery. Because every heart attack is more than a medical emergency. It is a life at risk, a family hoping, and a moment where knowledge, prevention, and care can change the outcome. In 2015, the movement began with a clear mission: to save lives from heart attacks. In 2020, the movement transformed into SHAKE, and the Shakeheart Conference was born. Continuing the journey with purpose, awareness, and action. Year after year, the movement grew, educating, empowering, and uniting professionals with one responsibility: to protect hearts and save lives. Preventing deaths and damages from heart attacks is not just a theme, it is a responsibility. With visionary leadership and the dedication of committed medical professionals, Shakeheart continues to inspire conversations that matter and actions that can save lives. Shakeheart 2026 marks a proud milestone, the 10th annual conference. More than a conference, a platform for knowledge, a gathering of purpose, and a movement for better heart care. For every life that can be saved, every family that can be protected, and every heart that deserves another chance, the mission continues. Shakeheart 2026, continuing the mission to save lives. Witness SHAKE, a movement that continues.
Thank you. So good afternoon and a very warm welcome to all of you. Our distinguished colleagues, esteemed faculty, and dear friends. Cardiovascular diseases, particularly acute myocardial infarction, remain the leading cause of mortality worldwide, accounting for nearly 17 million deaths annually. This staggering burden continues to challenge healthcare systems and underscores the urgent need for continuous education, awareness, and timely intervention. With this vision, we began our journey in 2015 with a humble initiative to disseminate knowledge and improve awareness. This effort evolved into SHAKE, Saving Heart Attacks Key Efforts, which was formally launched in January 2020 under the esteemed patronage of Dr. Azad Moopen, Chairman of Aster DM Healthcare Group. Our mission has remained steadfast to advance education for healthcare professionals while simultaneously engaging the broader community in cardiovascular prevention. It gives me immense pleasure to welcome you to the 10th Annual SHAKE Conference, an important milestone in our journey. This year's symposium focuses on preventing deaths and minimizing damages from heart attacks, a goal that resonates deeply with all of us in clinical practice. We have designed this as a highly interactive, primarily in-person conference, complemented by live streaming to broaden its reach. The scientific program is comprehensive, featuring over 25 lectures delivered by more than 40 distinguished national and international faculty members. These sessions are structured to address practical, real-world challenges and are relevant to a wide spectrum of healthcare professionals involved in cardiovascular care and prevention. We are pleased to share that this conference is accredited by the Dubai Health Authority with 7 CPD points, reflecting its academic rigor and clinical relevance. As part of this milestone year, we are also privileged to honor a select group of distinguished faculty members with the Fellowship of Sheikh. Though this list is not all inclusive, yet this journey will continue, but we have to start from somewhere and we have to honor some people, not all at the same time, maybe. This recognition celebrates their outstanding contributions to cardiovascular medicine, education, and their continued commitment to improving patient outcomes. I'm confident that this academic endeavor will significantly enhance our collective knowledge and contributes meaningfully to improving cardiovascular outcomes in our communities. I would also like to take this opportunity to acknowledge the tireless efforts of our organizing team, who have worked relentlessly over the past several weeks to bring this conference to fruition. Our sincere gratitude also goes to our partners and supporters for their invaluable contributions to this educational feast. Thank you so much. And I wish you all a highly engaging and enriching conference this and year after year. Thank you so much. Dr. Azad Moopen has specifically sent a message, our patron of the Sheikh. So,
dear esteemed faculty, delegates, and participants, it gives me great pleasure to extend my warm greetings to all of you on the occasion of the 10th edition of the Shakeheart Conference. Over the past decade, Shakeheart has served as an important platform for advancing knowledge, sharing best practices, and strengthening our collective commitment to reducing the burden of cardiovascular disease. Heart attacks continue to be one of the leading causes of mortality worldwide, and timely intervention, awareness, and continuous medical education remain critical to saving lives. I congratulate Dr. Brajesh Mittal and the organizers, faculty members, and participants for their dedication to this noble mission. The presence of distinguished experts from across the region and beyond reflects the growing importance and impact of this initiative. I wish the conference every success and hope that the deliberations and discussions will translate into better patient outcomes and healthier communities. Thank you, and my best wishes to all.
with this, we'll start fellowship, not a very formal one, but just as a recognition. So, generally, what I have thought is those who are very senior members who have attended or represented and have been faculty for over the years. So we have picked up some names, and we'll keep picking every year. So my first invitee is our senior most delegate in the session, Dr. Azad Binbrik, and I respect him a lot. He has this keenness of attending the conferences and learning even at this stage. Last month he was in Paris. So you are a torch bearer for all of us, and you encourage us and motivate us to go into more education. So please, sir, you are most welcome. Small bouquet. Small. Also. Okay, I'll go down. Yes, yeah. Just have a photo here. The next I call upon, with respect, Dr. Rajiv Lochan, and always been a faculty, a very, very senior cardiologist in UAE, was a very senior cardiologist in India. We worked together. I do appreciate your advancement toward cardiology education. So another great academician is Dr. P.K. Gupta. Since first until 10th, he has always been a speaker, and he deserves really a recognition. Our another worthy colleague, Dr. Amrish Agrawal, a very good speaker, a very knowledgeable doctor, and I'll be very happy to honor him. Is Dr. Peter Kala online? If yes, then
I am with you.
I call upon Dr. Laila, also a very, very worthy, well-known, and one of the few lady cardiologists in Dubai. Please, Dr. Laila. Can you give a bouquet? We have Dr. Peter Kala online.
Yes, I'm here.
Good
I am with
afternoon.
you. Hello.
Thank you so much. Dr. Peter Kala, since 2015, has always been a faculty. He is a professor in Prague, a very well-known cardiologist in Europe, but he has never missed a single of none of our meetings in last 10 years. Initially, he used to come pre-COVID era in person, but not anymore. Unfortunately, he's not able to come. But we believe that one of these years, he will be certainly joining us in person. And I'll be very happy to felicitate you with this a small token of appreciation.
Thank you very much, and good luck with the meeting and all your efforts.
We will arrange to send it across. Thank you so much. We have some a bit younger but very prolific cardiologist, Dr. Georgie Thomas. Is Dr. Georgie here? We have one more colleague here. He has come all the way from India, has been our part of the process since the beginning, since 2015. He's a cardiac surgeon, he's a COVID warrior, and he's my friend. And he's from India. He's coming over. He's very highly supportive. He's highly motivating. And he's one force behind me who pushes me to every time continue with your Shakeheart meeting. Dr. Ajit Jain, please come over. Dr. Ajit Jain. Is Dr. Rupesh Singh here? A senior, but bit junior to us. If he's not here, we'll hand him over later. We have two more recipients. Both are in US. They are our speakers in the evening. Dr. Fayaz Shawl and Dr. Robert Gigliano. Can you give me their one by one? So,
Thank you.
oh, you are there. You are there once again, Dr. Fayaz Shawl. Thank you for being so committed all the time, every year, year after year, on a Sunday in your early morning hours, and you dedicate to us. So nice of you. And this is what a small token of appreciation we want to present to you.
Thank you very much. Thank you very much.
Thank you. And last is Professor Gigliano. Thank you so much. We are almost on time. I'm so sorry. Dr. V.K. Mishra, a very senior cardiologist based in Abu Dhabi. Sorry for my brain fogging. I'm sorry. I would just like to felicitate Ms. Renita as a mark of appreciation. Can you give me a... Please come over. So in our 10th annual meeting, this is the first time ever that a faculty is a non-doctor, a non-physician, say beside non-cardiologist. Thank you. We have the plaques made for each and every sponsoring company, whom we will be handing over at another time and a more relaxed time outside or later on personally. But we do appreciate your efforts and your support. So thank you so much. We now break for lunch. We'll be back at 2:30. We are only 4 minutes late in our current proceedings. So thank you. Thank you for keeping up the time.
Thank you very much.
Thank you. Thank you, Doctor.